Sir, we are live now.
Okay. Hello, dear students. Hope audio video everything is okay. So very warm welcome to all of you at this amazing, beautiful platform. Myself, Dr. Shrikant Verma. So let's get ready for all the beautiful discussion. Okay, I'm just looking for the two technical settings. Yes, I got the chat box also. Yes, I can see. I can see. Tanay, good evening, beta. Namrata, namaste, beta. Vaishnavi, hello, beta. Hello. Hope you all are fine. Yes, it is. It is YouTube session. It is live YouTube session. Tanay. So
Yes.
there will be the little gap will be there. Okay, because it is YouTube live. So I can see the wonderful students here, Tanay, Namrata, Vaishnavi. So can we start this amazing session, beautiful session? So let's start this amazing session with this beautiful lines. सिर्फ हंगामा खड़ा करना हमारा मकसद नहीं, कोशिश है कि सूरत बदलनी चाहिए। तुम्हारे सीने में नहीं तो मेरे सीने में ही सही, मेरे सीने में नहीं तो तुम्हारे सीने में ही सही, कहीं भी हो आग लेकिन ये आग जलनी चाहिए, ये आग जलनी चाहिए, ये आग जलनी चाहिए। Hello, dear friends. Again, very warm welcome to all of you at this amazing, beautiful platform. Myself, Dr. Shrikant Verma. So, as all you know, that 2024 batch has been started in the different colleges of the India as well as abroad. And yes, anatomy is very basic science. Remember, beta, if your anatomy is strong, then every all other subjects will be strong. If your first prof is strong, then your second MBBS, third MBBS, the final MBBS, internship, and entire doctorate career will be stronger and stronger. So we are initiating this beautiful discussion. 10 questions of the anatomy, 10 questions of the physiology, 10 questions of the biochemistry, and with the preparation of the university exams, then we will touch our MCQs exams, NEET PG, INI CET, even the FMGE. Yes, it will be very helpful for the next exam also. So hope you all are ready. तो इस लिंक को यस प्लीज शेयर दिस लिंक टू ऑल योर फ्रेंड्स. दिस इज द वेरी ब्यूटीफुल अमेजिंग session for all of you, and remember, this is the magic of the anatomy. So with lots of the magic, I'm going to show you this anatomy. You will enjoy this anatomy too much. With the lots of the magic, I will do the magic, and I will get the disappear. Just see, अपने दोस्तों को पहुंचा दो, अपने दोस्तों तक बात पहुंचा दो, एनआरटी पढ़ने का नजरिया बदलने जा रहा है. जस्ट सी, शाकालाका बुम बुम, शाकालाका बुम बुम, शाकालाका बुम बुम. Yes, I can get disappear, and you will see this magic of the anatomy so beautifully. Totally, the anatomy study pattern is going to change again with the next magic. And you will see the magic of the anatomy. This wand of the Harry Potter is going to vanish, and it is converting to the Thor hammer. Yes. So anatomy study is going to change. Let's start this beautiful anatomy discussion. So can we start? Yes, ho jaye to emojis. So if you all are enjoying, just raise your hand, send the different kind of the emojis. Okay, so let's start this beautiful discussion. Okay, मैं यहाँ पर emojis देख रहा हूँ. Lots of the heart are floating here. So let's start the discussion. The first question by option. Option A, aponeurosis. Option B, tendons. Option C, fasciculi. Option D, ligaments. Yes. Tell me, beta. Yes, Akshay Kumar. Jai Gurudev, beta. Jai Gurudev. Vaibhav. Yes. Are you ready? Okay. This is the special session for the first MBBS, but all the students who want to prepare their anatomy very strong, they can join. Okay, it is especially the session for the first MBBS students. Okay, yes. So here I can see Dr. Belladonna D, Megha is saying D, Tanmay is saying D. Very nice. Infinity origin saying the ligament. Very good. Govind, Ronak, Gaurav, you all are amazing. Ligament. Very nice. So just tell me, beta, what is the aponeurosis? What is the tendon? What is the fasciculi? What is the ligament? From the basics, it is a special session dedicated for the first MBBS. Yes, again with the three-dimensional anatomy, the beautiful three-dimensional anatomy with the Jarvis anatomy. Sir, whenever you are looking any muscle, this is our arm, Iron Man anatomy. So here you can see our biceps muscle. Yes, sir, this is the biceps muscle. So in any muscle, there are the two ends. One is origin, another is insertion. One is origin, another is insertion. And you can see the contractile part, belly, non-contractile part is known as tendon. Yes, sir. What is the tendon? Non-contractile part of the muscle is known as the tendon. Biceps is having the biceps tendon. But there is the one more part which is flat. The flat tendon is known as aponeurosis. The beautiful diagrammatic presentation. Yes, lal fool, neela fool, anatomy beautiful. Sir, this is the aponeurosis. Getting the point? Sir, this is the belly, contractile part of the muscle. This is the tendon, non-contractile part of the muscle. And you can observe the flat tendon, aponeurosis. Agree, beta? Everyone getting the point? Okay, so we are going to clear all the concept properly. And what is the ligament? Sir, ligament is nothing. Whenever the two different bones are articulating together. Yes. So the two bones are articulating together. The one small fibrous structure which is joining the two bone is known as ligament. So these all are very basics and the very important fact for your entire life. Don't get confusion. What is the aponeurosis? What is it? Fasciculi. I will tell you about the ligaments again with the proper description. Sir, this is the bone. Here is a muscle. Muscle attached with the bone with the help of the tendon. Okay, sir, we are going to look the aponeurosis. Here you can see the palmaris longus tendon. And this tendon is getting flat structure. Sir, this flat structure is known as aponeurosis. What I want to tell you, sir, here you can see the tendon. Sir, here is the our aponeurosis. Agree, beta? Getting the point? Okay. Yes, sir. And this is our tendon. So remember, when tendon becomes flat, then it is known as aponeurosis. Yes, I am going to tell you the ligament. Sir, there are the different bones. You can see this is the our hip bone, ilium. Sir, here is the our another bone, femur. So different bones are getting attachment with the help of the ligament. Yes, sir. So these are the ligament. Later I will teach you. This ligament is attached between the ilium and the femur. So this is the iliofemoral ligament. I can see the students of the NEET are also here. Tell me, beta, this iliofemoral ligament, one special point. Yes, if you are first MBBS student, then even one special point. What is the very, very important fact about this? Sir, this is also known as the ligament of Bigelow, and it is the strongest. Yes, sir, it is strongest ligament of body. Don't forget this important fact from the your entire anatomy, from the your general anatomy. MCQ. Such kind of questions are asked in your NEET PG INI CET exams. Agree, beta? Okay, sir. More things. What is the fasciculi? Can you see? Sir, bones are giving attachment to the muscle. Yes, sir. So muscles are getting attachment with the help of the tendon. Right, sir. So the covering around the muscle made by the deep fascia known as perimysium. Right, sir. Now within the muscle is made by the different bundle. Yes, these bundles are known as fascicle. When you will see within the each fascicle, it is made by the smallest unit, that is the muscle fiber. Yes, the covering of the muscle fiber is known as endomysium. Are you getting? Endo means you can say bhitar, under. So innermost covering on the muscle fiber is known as endomysium. The covering of the fascicle, sir, the covering of the fascicle, yes, you will see there is the our perimysium. Yes, sir, perimysium. Agree, beta? Yes, if any doubt, you can ask me. And the outermost covering around the muscle is known as epimysium. Agree? Fine. So these are fascicle. What I want to tell you, in this question, we are dissecting each and every option. Sir, aponeurosis is nothing. It is the flat tendon. Yes, sir. What is a tendon? Sir, non-contractile part of muscle. Yes, sir. Sir, fasciculi. Fasciculi is nothing. It is the bundle of muscle fiber. Yes, sir. Ligament. Ligament is nothing. It is the small fibrous structure or fibrous band which is joining two near bones at joint. So in this question, articular bones are joined by the our ligament. Answer is the ligament. Everybody clear? Okay. Yes. So for the first MBBS students, just tell me, beta, this knowledge is very important. This knowledge is very important. So can you tell me again, sir, any muscle? Yes, sir. Any muscle is having the two parts. Yes, sir. One is contractile part from the very basics for the first MBBS is non-contractile part. Agree, beta? Everyone getting the point? Yes, statho boy MBBS. Everyone getting the point? Sir, the contractile part is known as, tell me beta, contractile part is known as and non-contractile part is known as, what is the normal? Yes, जिसने भी सही आंसर दिया उसको बढ़िया बढ़िया टिकट मिलेगा। दुनिया बहुत छोटी है, हम कभी ना किसी किनारे में जरूर मिलेंगे और हम गोलगप्पे पार्टी करेंगे। सो टेल मी बेटा, यस, कॉन्ट्रेक्टाइल पार्ट इज नोन एज एंड नॉन कॉन्ट्रेक्टाइल पार्ट इज नोन एज। ओके, अनदर थिंग, every muscle is having the two ends. Yes, what are the two ends? You can see here, you can see there. Sir, one end is known as origin and another end is known as insertion. Agree? Very nice, Govind Sitawar. Okay, very nice. So remember, the contractile part is known as belly. Sir, non-contractile part is known as tendon. Okay, origin, one point, any muscle is having the two end. One end is relatively fixed, less mobile part, that is known as origin. The another end which is relatively, yes, you will see, more movable, sir, that is known as insertion. So remember, any muscle is having the two end and two parts. Any muscle, so you have to remember the magic of two. What you have to remember, beta? Sir, this is the magic of two. Muscle is having the two ends, two parts. Okay, sir. Notes for the first MBBS students. Sir, what are the two end? Sir, the two end, one end is origin and another end is insertion. Right, sir? Origin, the part which is relatively fixed. Getting the point? Suppose this is the magic. Abracadabra, gilly gilly, choo. Yes. Now I'm having the Thor hammer. And remember, no one can raise the Thor hammer, only those people who are worthy. Yes, I am worthy. It is lots of the, it requires lots of the strength. Okay. So when I am elevating any heavy weight, the biceps is helping. So what is having? The biceps, this upper end is less mobile, but lower end is more movable. So upper end, which is less mobile, which is fixed, that is known as origin. The lower end, which is more movable, that is known as insertion. Hope everybody clear. So just see the magic. Yes, shakalaka boom boom, shakalaka boom boom, shakalaka boom boom. Yes, this is the magic. Okay, so just change the study pattern of the anatomy. It is very interesting. So don't forget the origin and insertion. Also remember the two parts. Sir, there are the two parts. What are the two parts? Sir, there is the our contractile part known as belly and non-contractile part tendon. Correct, sir. Now, more term for all of you. Sir, tendon. This tendon, yes, sir. This tendon, I'm going to tell you about the, yes, I told you about the tendon. When this tendon becomes flat, yes, so Flat tendon. This flat tendon is known as aponeurosis. Yes, sir. This is the aponeurosis. चपटा टेंडन क्या कहलाता है? चपटा टेंडन, दिस इज द अवर aponeurosis. Yes, Kirti, this is the difference. Kirti, the tendon is rounded but aponeurosis is flat. Tendon is near about rounded but aponeurosis is flat. This is the difference. Okay. Yes, again I am showing you in this beautiful way, three-dimensional way. Yes, you can see the Iron Man anatomy, the three-dimensional anatomy, the biceps. The upper end, which is less mobile origin, lower end more mobile. Yes, that is the insertion. Here you can see the rounded part, non-contractile rounded part. Sir, this is the tendon, while the flat part, flat tendon is known as aponeurosis. टेंडन गोल गोल होता है, एपोनेसिस चपटा होता है. टेंडन गोल गोल होता है, एपोनेसिस चपटा होता है. चपटा टेंडन एपोनेरोसिस कहलाता है. ओके, वन मोर पॉइंट. यस, थैंक यू कीर्ति. यस, समझते चलो, आगे बढ़ते चलो. ओके. यस आयुष, जो आंसर देगा उसको 50 रुपीज मिलेगा. ओके, रिमेंबर there is the one more point. There is the interdigitating fiber of the muscle or tendon. This interdigitation is known as raphe. Are you getting? Raphe is very strong structure. There is the interdigitation of the muscle fiber. Just do the hand with me. Yes, ऐसे करो, ऐसे करो, ऐसे करो, ऐसे करो, ऐसे करो. So there is a very, very strong structure is formed, interlocking. So strong interdigitation. Maybe the muscle fiber, maybe the tendon, maybe the aponeurosis. This interdigitation is known as raphe. Again, where is the raphe? I am showing you in the beautiful three-dimensional anatomy. Lal fool, neela fool, anatomy, beautiful. I will show you the abdomen. Cut it. Yes, there are the lost of the muscle. These all the muscles we have to remove. These all muscles are interdigitating together and they are making the one line in the abdomen. Can you see this line? Yes, this line is the interdigitation between the different kind of muscle of the abdomen and they are making the one white line in the abdomen. White means albumin. Whenever there is a alba word, albumin, albinism, any word, alba means white. So this is the line which is whitish. So this is a linea alba. Remember beta, linea alba is the aponeurosis. No, it is the interdigitation between the different kind of muscle fiber, tendon, or the you can say the aponeurosis. Yes, this is the raphe. Linea alba is the very strong raphe of the abdomen. Okay. Yes, beta, this is the class especially for the first year, but all the other students who want to make their basics strong, they can join it. Okay, fine, sir. So these are the things which you have to remember. Done. So we had completed this all the fact. I think there is no doubt we had completed the aponeurosis, tendon, fascicule, and the ligament. Done. Every point we dissected. Now I am going to tell you the next part. So get ready for the next question. Nutrient artery runs. So this is the question. Nutrient artery. I'm going to show you the magic. So just look here. मैं यहां से जाऊंगा और उधर से आऊंगा. So just look for this question and give me the answer. Give me the answer. Give me the answer. Okay. So you will observe this beautiful question, and this is the gift for all of you. Yes, just see my entry. I am coming from the different side with cutting my body. So just tell me, beta, the nutrient artery runs where? A, away from the metaphysis. Option C, away from the epiphysis. So we are looking away from the epiphysis. So these are our different points which you have to remember. Tell me, beta, tell me what is your answer. So again, I'm entering from this area. Tell me. Yes, very. So the students are here from the Bombay also. Okay, sir. So away from the metaphysis, towards the metaphysis, away from the epiphysis, or towards the epiphysis. To know this answer, I'm going to tell you the different parts of the bone. So tell me, beta. Yes. So Digvijay is saying B. Anjali is saying B. Govind is saying B. So just observe this point. Sir, any young bone is having the shaft. Sir, this is known as diaphysis. Agree, beta? Sir, ends of the bone, the ends of the bone known as epiphysis. Every long bone is having the one shaft diaphysis, two ends known as epiphysis. Agree? Now capture the of the diaphysis known as metaphysis. Are you getting? Meta means middle. So what are the different parts of the young bone? Very important for the first MBBS general anatomy: epiphysis, diaphysis, metaphysis. Every long bone is having the one diaphysis and two epiphysis. Okay, sir. And the cartilage plate. Yes, sir. This cartilage plate is simply the growth plate cartilage. Here is the active division. Later, what happens? There is application. The NEET PG 2024 question. Sir, this is the first MBBS topic. Sir, this is the first MBBS topic which had been asked in your NEET PG 2024 on 11th August. Question. Try to understand which type of the joint is present here. Later, what happens? Sir, this is the our young bone. Yes, sir. It is our young bone. Are you getting the point? Fine. Yes, sir. But adult bone. How? Sir, later what happens? There is the ossification. There is a ossification in this zone, in this cartilage. Okay, sir. So young bone converting to the adult bone, and it is having the only the shaft. Sir, it is having only the shaft and ends are there. Agree? So you epiphysis. Yes, this is epiphysis. So adult bone is having only the two parts, epiphysis and diaphysis. Every young bone, every adult bone is having the two epiphysis and one diaphysis. But young bone, they are having the four parts. Adult bone, they are having the two parts. Epiphysis in the young bone, diaphysis, metaphysis, and the growth plate cartilage. So there is a present between the our epiphysis and diaphysis. Tell me. Okay. Okay, Ayush. Just tell me, Ayush, you are from the first MBBS or the intern or post intern? First MBBS or non-theory student? Okay. आवाज में. Oh, I'm trying to clear this one. Yes. Hope now it is okay. Okay. So tell me which type of the joint is present between the epiphysis and the diaphysis? Yes. Tell me. Sir, this is the our cartilage. So definitely this is the our cartilaginous joint. Sir, this is the our cartilaginous joint. This is the cartilaginous joint. Because later this cartilaginous joint is replaced by the our bone. So that's why it is primary cartilaginous joint, which is also the synchondrosis. Done? Okay. Now look further. Sir, nutrient artery. Every bone is having the our blood supply, right, sir? Sir, this is the first MBBS group, so we are focusing for the concept. So just observe here, sir. Artery is entering in oblique direction, bone is leaving structure. So this artery which is supplying the bone is known as nutrient artery. And this opening foramen from where the nutrient artery is entering, sir, this is known as the nutrient foramen. Very important for the first MBBS students. Okay. Yes, Viket, thank you. Are you getting? So now this nutrient artery is dividing into the ascending branch and descending branch, right, sir? Now ascending branch, it is supplying the medullary cavity, it is going towards the metaphysis, and near the metaphysis, it is making the hairpin band. Yes, it is making the hairpin band. What you have to remember, sir, near the metaphysis, it is making the hairpin bands. Okay, so this nutrient artery is dividing into the ascending branch, and this is the descending branch, which is reaching to the metaphysis and making the hairpin band. Agree, everybody? Clear? Okay, so remember, the question is asking, nutrient artery runs away from the metaphysis? No, sir. It is running towards the metaphysis. Towards the metaphysis, right, sir. Away from the epiphysis? No, sir. Towards the epiphysis? Right. But if you will see, this is the controversial question. Who is wife of Salman Bhoi? 4 options will be given. Okay. Aishwarya Rai, Katrina Kaif, Lulia, Jacqueline Fernandez. You will say, sir, none is the answer, but none is not given. Sir, all of the above. Yes, but all of the above is also not given. Then you have to go for the update. Yes, Aishwarya Rai auntie, you cannot opt. Why? Because now she is married to the Bachchan family. Okay, Abhishek Bachchan ji. Okay, so you cannot mark. Then you will opt the Katrina Kaif. But as you will opting the Katrina Kaif, how's the Josh will get down? चांद सितारे वो बाद में तोड़ लाएगा, पहले हमारा सिर फोड़ लाएगा. So Katrina Kaif is now not the answer. Lulia, yes, before 4 year, 5 year, Lulia was the answer in the media, but now no, it is also not right. Then Jacqueline Fernandez, at the lockdown time, Jacqueline auntie went to the farmhouse. So Jacqueline auntie is your answer, but the most updated answer, the Karishma Hazarika. Okay, Taj Mahal is situated. Agra is the best answer. But if Agra is not given, then next nearby answer is the UP. UP is not given, then Delhi. Delhi is not given, then India. India is not given, then Asia. Asia is not given, then Earth. Agree, beta? So this is the controversial question pattern. They will make the 2 answer. So what is your better answer? Which is the best answer? Yes, yes. कृष्णा बताओ कौन गया था अभी रिसेंटली फार्म हाउस में? अगर समझ में आया तो हो जाए इमोजी. यस 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 यस. टेल मी बेटा, टेल मी सर. देयर आर द आवर डिफरेंट आर्टरीज. सर, व्हाट इज द आवर बेस्ट आंसर? दिस आर्टरी इज रनिंग टुवर्ड्स द आवर मेटाफाइसिस and epiphysis, but close answer is the metaphysis. So remember, in this question both are right. Controversial question, but the our B is better answer than towards the metaphysis is better answer than D. Both are right, but single answer B will be best. Okay, yes Numan, you are right beta. Agree everybody? So nutrient artery runs answer our towards the our metaphysis. Okay, so now we are moving for the next clinical integration. Now see, sir, later this part is ossified. So growth plate and our this particular metaphysis area is obliterated. So remember, whenever there is the infection, especially which bacteria? Staphylococcus aureus. MCQ. Staphylococcus aureus. Yes, it is coming and getting trapped in this hairpin band because here is the sharp turn. So bacteria is getting trapped here. So this is the most common site for the osteomyelitis infection. MCQ. Now this metaphysis is found in the children. So most common age of the infection. Yes, remember, it is most commonly seen in the child. Okay, why? Due to the our hairpin band. So this osteomyelitis infection is commonly seen in the children. Why? Because this hairpin band is found in the children, because the metaphysis is found in the our child bone, in our young bone. But remember, in the adult this is not present. In the adult it is not present. So in the adult the bone infection is very less common or not found. Okay, and which is the most common bacteria which is causing the infection? Answer is the Staphylococcus aureus. Everybody clear? Okay, yes sir. Yes, Kiran Chetri, just tell me, you are first MBBS or the final year? Because it's the first MBBS dedicated batch. That's why slowly we are creating the concept. And I told you the orthopedics. At the platform, the anatomy. Okay. Yes. So these are the things. Now come to the our next. This is the our artery point. Yes, Kiran, you are right, beta. So this is the nutrient artery, ascending branch, descending branch. Here the our hairpin band, where this is anastomoting. Okay, sir. Now tell me, yes, direction of the nutrient foramen. I will tell you about this direction of the nutrient foramen. But right now, you know the nutrient foramen. In our upcoming classes I will tell you the direction. Sir, nutrient artery is growing. Nutrient artery is running downward. So the growing end is upward. just opposite. So you will see in the our fetus, in our baby, in our body, that to the elbow I go, nutrient artery, they are going towards the elbow in the humerus and radius ulna. So the growing end will be opposite, upper end and the lower end. Yes, from the knee I flee. So nutrient artery is following opposite direction, so the growth end will be around our knee joint. So these are the more points. You remember this, all the things with the different kind of the images. Just you have to do this one, you have to do this one. So what you have to remember, beta? Yes, to the elbow I go, nutrient artery, they are going towards the our elbow, and from the knee I flee. So this is the way, this is the way how you can remember. Agree? Very nice, very nice, Kiran, very nice. You are from the first MBBS. Yes, which college, beta? Which college? Yes, derivative of the neural crest. So we will see this neural crest derivative at our embryology part. Okay. Yes, Ajay Devane is here. Okay. So tell me, derivative of the neural crest cells, all are except. Very good, very good. Vishwas, Omar, NEET, Ajay Devane, you all are right. Answer is the D. Okay. So in our embryology part, I will teach you, sir, during the development, this is my notes. We will discuss in detail in our embryology part. But sir, there is a ectoderm, mesoderm, and endoderm. Now the ectoderm is showing the thickening and it is changing into the neuroectoderm. Remaining part is known as the surface ectoderm. Now this neuroectoderm is making the plate-like structure. This is the neural plate. While you will see the mesoderm is dividing into the lateral plate-like structure. Yes, around the axis, paraxial mesoderm, and between the paraxial and the lateral plate mesoderm, there is the intermediate position. So intermediate mesoderm. So you can remember LIP, our very beautiful mnemonic. Your mnemonic is LIP, LIP. So mesoderm is dividing into the our lateral plate mesoderm, intermediate mesoderm, and the paraxial mesoderm. And what is happening with this our neural plate? Neural plate is getting, yes, the groove like structure. So this is the neural groove. When the groove is formed, then corners are getting elevated. These corners are known as the crest, because it is derivative of the our neural plate, neural groove. So this is known as the neural crest, and the cells within it, these are known as the neural crest cells. Okay, sir. So now we are having the clear concept, neural crest cells. To understand this concept, the development of the CNS, I always give one example. Sir, suppose, yes, try to understand. Suppose this is the neural plate. Okay, sir, this is the neural plate. Now there is the neural groove. Yes, sir, there is a formation of the neural groove, and the corners are meeting together. So it is making the, yes, the neural tube. Sir, this is the neural tube. The neural tube is having the anterior neuropore, the neural tube is having the posterior neuropore. What I want to tell you, sir, the development of the CNS, neural plate, and then neural groove, and then corners are meeting together and making the neural tube. Yes, this is the anterior neuropore, this is the posterior neuropore. In embryology section, I will tell you, sir, the cranial end will grow. The cranial end will grow. It is growing at the our middle part of the body. The cranial end will grow and it will make the brain. The caudal end will remain narrow, it will make the spinal cord. So this is the development of the central nervous system. So development of the central nervous system in 30 seconds. Neural plate, neural groove, and neural tube. The cranial end, anterior neuropore, the caudal end, posterior neuropore. Anterior neuropore is closed on the 25th day. MCQ, NEET PG. The caudal end, the posterior neuropore, it is closed on the 28th day. Yes, this is the NEET PG exam. So I told you the corners of the our neural groove, these are known as the crest cells. These are the neural crest cells. Okay, very nice, very nice. WhatsApp dude, I am post intern as well as sir is teaching great concepts. Thank you, WhatsApp. Yes, beta Ajay, this is especially for the our first MBBS student, but any student who is who want to clear their concept, they can join. Okay. Yes, thank you, Ajay. Thank you for your positive words. Yes, WhatsApp dude. Thank you, beta. Thank you. Okay, sir. So this is our neural crest cells. Now, this neural crest cells in our body. This is the notes for all of you. Here, these neural crest cells, they are migrating in the body. Neural crest cells, they are developing. They are developing at the center of the body. Then they are migrating at the brain, making the meninges, in the eye, sclera, in the teeth, odontoblast, in the skin, melanoblast. So many structures they are making. One mnemonic for all of you. Sir, this is the our Banaras Hindu University. In front of it, there is the our, yes, Mahamana Madan Mohan Malvi. So this is the list for the neural crest cells derivative. You can remember PITS, Bache. They are doing disco in front of the Mahamana Madan Mohan Malvi. Otherwise, you can remember the Man Mohini Mallika. बच्चे जो हैं वो डिस्को कर रहे हैं किसके सामने? मनमोहिनी मल्लिका के आगे. सो व्हाट आर द आवर न्यूरल क्रेस्ट सेल्स डेरिवेटिव? व्हाट आर द आवर डिफरेंट न्यूरल क्रेस्ट सेल्स डेरिवेटिव? रिमेंबर पैरासिम्पैथेटिक गैंग्लियन, यस, एंट्रिक प्लेक्सस, यस, autonomic nerve system ganglion, dorsal root ganglion, Schwann cell, dentine tissue, or odontoblast, but not the amyloblast, not the amyloblast. This is the question. Sclera, choroid, connective tissue of the thyroid, parathyroid, all the gland of the head neck area, as well as melanocyte. In the option it is given mesenchymal bone of the head neck face and the meninges. These all are the neural crystals derivative, but not this our amyloblast. So answer is the amyloblast. Okay. Okay, sir. So now move for the our next question. We are going to talk about our next question, the incorrect statement about the metaphysis. I think we had discussed. Okay, epiphysis, diaphysis, metaphysis, as well as our growth plate. Sir, it is the most vascular part. They are asking about the incorrect statement. Incorrect statement. It is the most vascular part of the bone. Okay, just see the option. Yes, the hairpin band are there. This region favors hematogenic spread of the infection. Yes, it is causing the osteomyelitis. This is the strongest part of the bone. No, 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 no. Strongest part of the bone is the diaphysis. We already discussed. It has the maximum growth activity. Perfect. All are right, but it is not the strongest part of the bone. The answer is the diaphysis. Am I right? Can we move? Okay. So let's move for the further. Yes, अर्ज किया है, शायरी की महफिल है, अर्ज किया है, स्टूडेंट्स की भी क्या लाइफ है, स्टूडेंट्स की भी क्या लाइफ है, ना हस्बैंड है ना वाइफ है, वो अपना दुख दर्द किसे बताएंगे, वो अपना दुख दर्द हम जैसे दोस्तों को बताएंगे. सो एनी काइंड ऑफ डाउट, एनी काइंड ऑफ प्रॉब्लम, प्लीज आस्क अस, डोंट फॉरगेट. ओके, रास्ता भी जानते हो, चलना भी जानते हो, तुम आग हो तबीयत से जलना भी जानते हो, खुद को मोम ना समझो जो झट से पिघल जाओगे, तुम सूरज हो डूबकर निकलना भी जानते हो. सो वी ऑल आर विथ यू. जस्ट सी द कॉन्सेप्ट एंड mark the answer. Your basics will be stronger and all the other subjects will be stronger. So move for the next option. I told you, sir, epiphysis, sir, diaphysis. I told you about the our metaphysis part. In the adult bone only the epiphysis and diaphysis are there. Okay, sir. Now move for this next question. Question number 5. Question number 5. Okay, तो अशोक ने यहाँ पर आग लगा दी है. अशोक ने आग लगा दी है. Okay, सूखे पत्तों की तरफ बिखरी थी एनाटॉमी. सूखे पत्तों की तरफ बिखरी थी एनाटॉमी. हम तुम मिले और फिर हमने आग लगा दी, आग लगा दी, आग लगा दी. चलो तो नेक्स्ट क्वेश्चन करते हैं. सर क्वेश्चन, which of the following statements is true about the pointed structure in the above image? So this is the our image. Okay, radiology image. Okay, sir. So just identify the different bones. Sir, this is the our radius. You can see the lower end is expanded. Okay, sir. So radius is on the lateral side. Sir, another thin bone is the ulna. So this is the medial side. Okay, sir. Can you see this particular part? Sir, this is elliptical surface and this is elliptical surface. So this is our radiocarpal joint and it is showing the elliptical surface. So this is which type of the joint? Ellipsoid joint. MCQ, very important. Fine. Okay, but another important MCQ, sir, this is the first metacarpal, second metacarpal, third metacarpal, fourth metacarpal, fifth metacarpal. So you can see here the surface, sir, the articulating surface is showing S shape. So this is the our saddle joint. Very most important for the first MBBS, for the your NEET PG exam. Remember the base of the thumb. It is very commonly involved in the rheumatoid arthritis. The medicine integration, in medicine you will see the rheumatoid arthritis. Rheumatoid arthritis is involving the first metacarpal joint. Okay, sir. And here you can see the bone. She looks too pretty. Try to catch her. The very famous mnemonic. Otherwise, yes, श्याम लाल टिंडे पकाओ, तुम्हारे टिंडे कच्चे हैं. So many concepts, so many mnemonics are there. You can make very interesting to the anatomy. Yes, there is a scaphoid bone, then lunate, then triquetral, then pisiform. Pisiform is very small, seed-like bone, sesamoid bone. Then there is a trapezium, trapezoid. Yes, there is a trapezium, trapezoid, trapezoid. This largest bone is the capitate, and this is the hamate, which is showing the hook. Okay, okay, sir. So this is the our carpo metacarpal. Yes, this is the carpo metacarpal joint. Okay, okay, sir. So this is our saddle joint. So the question, sir, this is the our hinge joint. They are asking what? True. It is hinge joint? No, sir. It is not hinge. It is ellipsoid. Na? It is ellipsoid. Agree, sir. The proximal articular surface includes the lower end of the radius and ulna. Yes, the proximal articular surface includes the lower end of the radius and ulna. No, remember here is a fibrocartilaginous plate which is separating. So it is again wrong. Remember, ulna doesn't participate. Ulna doesn't participant. I'm showing the three-dimensional beautiful orientation. Again, you can observe lal fool, neela fool, anatomy beautiful. How, sir? Just observe here. Just observe here, sir. This is the our radius, and here are the carpal bone. This is the ulna. So I'm removing this different structures. I'm removing this different structure. Can you see? There is a one small fibrocartilage plate. Yes, this is the radius ulna, and she looks too pretty. Try to catch her. Yes, sir. Scaphoid, lunate, triquetral, pisiform, trapezium, trapezoid, capitate, hamate. So you can see there is a one small plate, fibrocartilage. So this structure, this small fibrocartilaginous plate is separating the ulna from the our wrist joint. So ulna is never participating. So remember this question. Yes. Okay. So remember, this is not the our participating structure. Definitely. So now ulnar collateral ligament extends from the ulnar striate process to the triquetral pisiform. Yes. So just observe here. Sir, this is the our radius, this is the ulna, and this is the ulnar collateral ligament. So you will see on the radial side, radial collateral ligament giving stability to the wrist joint, as towards the ulna, this is the ulnar collateral ligament which is giving stability to the our wrist joint. Getting the point, beta? So remember, in the our ulna there is a small process, sir. This is our small process. What you have to remember? Yes, sir. So here is the our ulnar collateral ligament. You will see there is our ulnar collateral ligament. So this is attached from the our, yes, this ulnar styloid process to the our carpal bone. Okay, so you can observe this option. I had given the clear view. This statement is true. Adduction is caused by a simultaneous contraction of the flexor extensor capsularis. No, sir, it is not right. So this is wrong. So which statement is right? C. Very nice. Everyone getting the point? So we are preparing from the very basics of the all the things. Radiology integration. Yes. The same thing in your orthopedics, and I'm showing you the three-dimensional orientation. And right now it is very easy, but when you will study all the 19 subjects, then it will create the confusion. Okay, sir. Now come to the our question number 6. Which of the following is incorrect statement with respect to the basic anatomy of the bone? Yes, again, very simple question. The epiphysis of the long bone has cancellous bone structure. They are asking the incorrect. Yes, the diaphysis is the long bone that has compact bone structure. Yes, sir, it is also right. The compact bone does not have Haversian system. No, this is right. This is right. But compact bone is characterized by the Haversian system. This is wrong. The diaphysis is derived from the primary ossification center. Yes, diaphysis is from the primary center of ossification, while the epiphysis from secondary center of ossification. I think there is no doubt. I think there is no doubt. Agree, everybody? Yes, sir. Just observe, sir. This is the our bone epiphysis. Here is the narrow zone metaphysis. This is the diaphysis. Sir, diaphysis is characterized by the compact bone, and when you will cut this compact bone, you will see the solid Haversian system, in which at the center you will observe the Haversian canal, which are surrounded by the our, yes, concentric lamina. So this is the compact bone part, but at the medulla part, at the center part, you will see the medulla with the spongy structure. So this is the cancellous bone. Yes, there is a compact bone. This is the cancellous bone. So diaphysis is having the two part. Cortex, yes, it is having the Haversian system, and the medulla, sir, it is having the our cancellous system. Sir, there is our Haversian. Here is the cancellous spongy bone. There is a compact bone. This is our spongy bone. Right, sir. So we dissected this all, spongy bone and the compact bone. I told you spongy bone is also as the cancellous, and the compact bone is also as the cortical bone. Yes, again, the difference for the first MBBS. Okay, compact bone, outer layer of the bone. Spongy bone, interior of the bone, medulla, you can say. Structure, so compact bone is densely, but this is having the trabeculae. Spongy bone, they are having the trabeculae. Yes, these are soft. Sir, appearance, sir, compact bone is solid and dense, while this our spongy bone is honeycomb like. So there is the sponge. Many small openings will be visible. Function, so this compact bone is giving strength and support, while the spongy bone, it is supporting the metabolic need. Yes, as well as nutrition part, you can say. The blood supply, central canal, by the spongy bone, spaces between the trabeculi where the nutrition material are there. Density is high, density is low. Yes, location in the bone. So diaphysis, shaft and outer layer, but this is interior layer, the spongy bone. So this is a beautiful, beautiful table for all of you. Agree? Yes, perfect, perfect, Kiran Shinde beta. You're perfect, right? Kiran, you are going in a very, very right direction. So stay tuned with us. General anatomy is very easy, but as we will progress, upper limb, yes, it is interesting, easy. Thorax, very easy. Lower limb, very easy. But when we will reach to the neuroanatomy and the head, neck, face part, and then abdomen, they are very lengthy, very dangerous. So stay tuned with us. We will move step by step. We will deal with the easy thing and we will deal with all the difficult thing in the very easy way with the three-dimensional anatomy, as well as with our all the Avengers. Captain America will move with all the our Avengers. Yes, with the shield of the Captain America, with our Thor. So very, very interesting study we are going to do. Okay, sir. So move for the next question. Question number 7. Parenchyma of all the bone of the all the following gland derived from endoderm except. Yes, yes, yes. Sir, remember pituitary gland. It is the part of the brain, and brain is ectodermal. Do you remember? Right now I told you the ectoderm. Yes, sir. It was making the neuroectoderm, right, sir? Then neuroectoderm was making the yes, neural plate, neural groove, and then the corners we are meeting and making the neural tube. So easy. The CNS development in the 30 seconds. Sir, ectoderm is making the neural plate, neural groove, neural tube, anterior neuropore, posterior neuropore. The cranial end is making the brain, caudal end is making the spinal cord. So remember, very easy. The neural ectoderm, it is making the neural plate. Notes, neural groove, then neural tube. This neural tube is making the brain and the spinal cord. Agree, beta? Yes. So remember this pituitary gland. Yes, it is having the two part. The pituitary gland is having the two part. Sir, there is the anterior and the posterior pituitary. The anterior pituitary is coming from the roof of the mouth. From here, the anterior pituitary is coming. And here is the brain, diencephalon. It is giving rise to the posterior pituitary. Yes, the point you have to remember, from the roof of the our stoma or the mouth, the Rathke's pouch is coming. It is making the anterior pituitary. While the from the floor of the diencephalon, sir, there is the downward growth and it is making the posterior pituitary. So further, there is a formation of the pituitary gland. Agree, everybody? So the pituitary gland is coming from the brain. Brain is the ectoderm. So remember the pituitary gland, it is the part coming from the ectoderm also. So these all are endodermal, but the pituitary gland is having the ectodermal part also. Agree? So in the our yes embryology part, I will teach you, sir, there is a mouth cavity. It is giving rise to the Rathke's pouch. Rathke's pouch is going up. But the diencephalon floor, it is giving rise to the our small structure, it is going down. So you will see that our anterior pituitary is formed by the Rathke's pouch, but the posterior pituitary is coming from the our floor of the diencephalon. I will teach you in the embryology part, but right now, sir, all the glands, they are endodermal except pituitary gland. Yes, now these are the different things which I will teach you during the embryology part. But come to the question number 8. Yes, can you tell me, beta, question number 8? Mark the correct matched pair of the muscle with their muscle fiber arrangement. Okay, so I'm going to teach you the muscle fiber arrangement quickly. Okay, sir, look here, muscle fiber arrangement. Okay, so what I want to tell you, sir, any muscle is having the fascicle and the our tendon, two types of things. So these are the muscle fascicle. How these are arranged? So we are going to learn about the architecture, muscle fasciculi architecture. So remember, beta, these muscle fasciculi, they may be parallel to each other. Parallel. Yes, there may be the chances. Suppose this is the axis, but the muscle fibers, they are obliquely. This is the pen net. Okay. Sometimes you will observe, sir, muscle fibers, they are crossing to each other. So this is the cruciate. Yes. Sometimes you will see the muscle fiber is single, but they are changing the direction. So this is known as the twisted. What are the different types? Sir, there is the parallel. Sir, there is the pennate. Sir, there is the our crossing pattern, cruciate. Sir, there is the our twisted, or also you can say spiral. First MBBS question, and from the cadaveric image, the questions are asked on this basis in your NEET PG exam. Okay. Okay, sir. So parallel, there are again many types. Again many types. Okay. Like there is the our quadrilateral. Yes. There is the our strap like muscle. There is the our strap like muscle with tendonous intersection. Okay, sir. Also, you will see the fusiform muscle. There are the many types. Pennate muscle. Also, you will see there is the unipennate, sir, bipennate, sir, multipennate, sir. There is also one more thing, that is a circumpennate. Okay, so we discussed during our regular class, but right now I'm showing you the three-dimensional orientation. Look here, sir, the our parallel muscle fasciculi. Can you see the biceps? Beautiful. Can you see the muscle fibers are parallel together? Biceps is fusiform, parallel muscle fasciculi. Also, can you see in our head and neck part? Head and neck part, sir, there are the strap muscles. I'm showing you the strap muscles. Can you tell me? Can you tell me? These muscles are having very beautiful feeling from sternum to the thyroid. So these are having the parallel muscle fiber. So you will see, sir, this muscle is taking origin from the sternum going to the hyoid. So this is the sternohyoid. Yes, the longest muscle of the body. Anyone, can you tell me which is the longest muscle of the body? Tell me better, tell me. This is the INI CET question. The longest muscle of the body. Honeymoon muscle, Taylor's muscle. Sir, this is the sartorius. Sartorius is also having the parallel muscle fasciculi. Also, one very classical question you all know. In our first MBBS college, we had studied this all the things. Can you see this muscle? The six-pack ab muscle. This is the parallel muscle fasciculi, rectus abdominis, which is making the six-pack muscle in the abdomen. Sir, this is our, yes, rectus abdominis, the strap muscle with the tendonous intersection. These all are the our fibers with the parallel muscle fasciculi. Why? Look here, the unipennate, bipennate, multipennate muscle. Catch this one. Sir, if this is the axis and the fibers are arranged only in one direction, then it is known as unipennate. Pennate means a feather-like appearance. Sir, if this is the central axis, sir, if this is the central axis and the fibers are arranged on the both direction, then it is known as bipennate muscle. Yes, sir, this is the bipennate muscle. But you will observe, if there are the multiple axes, and the fibers are arranged on the every side. Yes, then it is known as our what? Multipennate muscle. Okay. And also you will observe one more arrangement. Suppose this is the central axis, important for the first MBBS university exam from the general anatomy. The fibers are arranged all around and they are making the one circular point. Yes, so this is known as the circumpennate. Yes, sir, this is the circumpennate. Now in the gross anatomy part, I will teach you the unipennate. Remember the unipennate muscle, the first and second lumbrical, sir, the first and second lumbrical, as well as the palmar introshite. These are unipennate. But the bipennate muscles are all the dorsal introshite, as well as remember the third and fourth lumbrical. Sir, multipennate, two fiber, the middle fiber of the deltoid, middle fiber, and the subscapularis muscle, circumpennate tibialis anterior. So these are the classical example. Agree, beta? Yes, serratus anterior is having the multiple digitation, but if we cannot count it in the multipennate muscle. Kiran, beta, are you getting the point? Serratus anterior is having the multiple digitation, but we cannot count it into the multipennate muscle. Two, deltoid middle fiber and the subscapularis. Okay, serratus anterior is having the multiple digitation. It is taking origin from the multiple ribs, but we cannot count in the multipennate. Yes, Kiran, you are very intelligent student, but please correct this concept, beta. Okay. Okay, sir. Now, what I want to tell you, cruciate means fibers are crossing together. Sternocleidomastoid. The classical example of the cruciate is the sternocleidomastoid and twisted. And don't worry if you are doing mistake. Any student, if you are doing mistake, beta, this platform is to do the mistake. This platform is to do the mistake, but after the mistake we will learn and then we will never do mistake in our main exam. बेटा याद रखना, हम गलतियां करेंगे और गलतियों से सीखेंगे. अरे गलती कर रहे हैं, अपनों के बीच में तो गलती कर रहे हैं, क्या दिक्कत है भाई? मैं गलती करता हूं, आप गलती करते हो, लेकिन गलतियों से हम सीखते हैं और फिर मेन एग्जाम में हम गलती नहीं करेंगे. सो वेरी नाइस किरण, यू आर अमेजिंग स्टूडेंट, यू आर गिविंग all the answers perfect. Very nice. Clapping from my side for the Kiran, for the Rajdeep, for the Anjali, for the Bhavar Singh. Yes, Rajdeep, you all are amazing. Thank you, beta. Twisted muscle. So during my classes, yes, just see the magic. Yes, shakalaka boom boom, shakalaka boom boom, shakalaka boom boom. Yes, are you looking the magic? I am having this Spider-Man. Yes. So suppose it is any muscle, but during the attachment, the upper fiber they are going down fibers they are going up. Yes sir, suppose it in any muscle, so during the attachment upper fibers they are going down fibers they are going up. So this is what, sir? This is the spiral or twisted. But when there are the two different sets of the muscle, one set here, another set is here, they are crossing to each other, so this is the cruciate. Okay, what is the twisted, what is the spiral? Sir, there is the one set of the muscle, okay, upper fibers they are going down fibers are going up, so this is known as spiral or twisted muscle. Remember the pectoris major and our latissimus dorsi, they are twisted. So now can you give the answer? First four dorsal interossei bipinnate, mark the correctly matched pair. Okay sir, 1 to 4 dorsal interossei, yes sir, these are bipinnate. Okay, 1 to 3 palmar interossei bipinnate, no, these are unipinnate. Okay, I told you. Sir, first and second lumbrical bipinnate, no, these are unipinnate. Sir, third and fourth lumbrical bipinnate, no, these are bipinnate. So definitely, yes, these four dorsal interossei, I will teach you, dorsally present in between the bone, interossei. मिर्जा गालिब कहते हैं, सारे राज नाम में दफन रहते हैं. Answer is A. Interossei, the muscles in between the ossei, in between the bone, these are known as interossei. Are you getting the point, beta? Hope you all are getting the point. So what I want to tell you, further, look here, question number last 9. Which of the following is not a projection from a bone surface? Yes, I told you, trochanter. Sir, there is a greater trochanter and the lesser trochanter. I am showing you these are the projection from the bone. So again you can see, yes, 20 रुपए की पेप्सी, anatomy sexy. See here, this is our femur. So you can see in the femur there is a one big projection. This is the greater trochanter. Yes, it is a projection from the bone. And you can see a small projection from the our upper end of the bone. Sir, this is the laser trochanter. Sir, it is the projection from the bone. So I had shown you, this is right. Tubercle, again I am showing you in the our humerus. Yes, again look here, the magic, I am showing you the magic. Abracadabra, gili gili choo. Yes, in my hand now you can see the femur. So in this part, can you see the our upper end? So this is a greater trochanter, here is a lesser trochanter. Both are bony projection. Yes, these are the projection from the bone. Now I'm going to show you the magic. Can you see the femur? So I'm just doing the magic. Abracadabra, gili gili shoo. Okay, so just I'm trying to make this one interesting. कोई ये नहीं बोलेगा कि सर नीचे कोई बोन गिरा, ये जादू है, कोई मुझे दोष नहीं देगा. So can you see I converted the femur into the humerus? So in the humerus, upper end, lower end, and shaft, and in the our upper end, can you see there is a one big projection? So big projection, greater tubercle, small projection, lesser tubercle. So again this is the projection from the bone. Okay, getting the point? So now again shakalaka boom boom, shakalaka boom boom. गायब हो गया bone. Okay, fine. So now what I'm going to tell you, sir, this is again right tubercle. Sir, the greater tubercle and lesser tubercle, these are the part from the humerus. Yes, these are the part from the femur. These are right, these are right. Trabecula, do you remember? It is our spongy bone. Yes sir, it is our spongy bone. And spongy bone, sir, it is not the projection, but it is inside the bone. So it is not the projection. Answer is this one. Tuberosity, like the gluteal tuberosity. Again, I'm going to show you the gluteal tuberosity. Just try to understand with this three-dimensional orientation. Look here, this is the our femur, and in the femur, this particular part, it is having the one rough area. Sir, this is the gluteal tuberosity. Again, it is the part of this our femur. This is the part of the our projection from the bone. I think there is no confusion. Trabecula is the answer. Agree? Yes, Bhavar, you are right, beta. Last question. Yes, see here the bone anatomy. Sir, cortex and the medulla. So here the medulla part inside, yes, end of the bone. This is the cancellous. This is the trabecule. It is inside the bone. Okay, sir. Yes, this is the inside part of the bone. Beautiful anatomy. Yes, sir. Now, last, the growth plate is which type of the joint? Tell me, beta. I told you. I told you. Sir, plane joint? No. Plane synovial joint, the articulating surface, they are plane. Sir, it is not the synovial. Fibrous joint means suture. No, sir. Not the fibrous joint. Primary cartilaginous? Yes. I told you at that time, there is the our diaphysis, epiphysis, the ends of the our diaphysis, that is the metaphysis. Okay, sir. And here is our growth plate, because here the cartilage. So definitely this is which type of the joint? Cartilaginous joint. Later what happens, sir? It is showing the ossification. It is showing the ossification. It is showing the ossification. It is replaced by the bone. So this is which type of the joint? Primary cartilaginous, because the cartilage is getting fused. Cartilage is showing the ossification. So this is also known as the synchondrosis. Syn means chipakana, chondro means cartilage. So this is the synchondrosis. Okay. So I think there is no confusion. Yes, this is our primary cartilage. Secondary cartilaginous, sir, remember there are the bones. I'm showing the three-dimensional anatomy. Sir, the cartilage is there. Yes, look here. Last part, just few minutes, cut this structure. So these are the vertebra. These are the vertebra. And in between the vertebra, intervertebral disc. Yes, this is the cartilage at the midline, showing the partial movement. Yes, this cartilage is not replaced by the our bone. So this is secondary cartilaginous. If replaced by the bone, primary cartilaginous. If not replaced by the bone, secondary. Okay. Also, you can observe. Sir, this is the pubic symphysis. So you can look here, the right and left hip bone, and in between the hip bone, this is the our cartilage. Yes, this is the cartilage. So this is at the midline, not replaced by the bone. So again, secondary. Also, you can see the our sternum. Also, you can see there is the our sternum. So this is the manubrium. Here is the body. So this is the manubriosternal joint. This is the manubriosternal joint. So this manubriosternal joint is again at the midline and showing the partial movement. So remember the classical exam of secondary cartilaginous joint, answer is the MIS. Sir, M for manubriosternal joint. Miss is your mnemonic. Okay, sir. I for intervertebral disc. Sir, S for symphysis pubis. Yes, sir. Symphysis pubis. Yes, these all are located at midline and showing the partial movement. So these all are the secondary cartilaginous, but here no movement in between the our growth plate part. So this is our, yes, primary cartilaginous joint. Agree, beta? So these are the things. When we will do the detailed classes, I will tell you entire classification of the joint in one page. So thank you very much. God bless you all. And now we are going to move for our next part. Yes, with this lines. So remember, कोई तुमसे पूछे कौन है एनाटॉमी, तो कह देना कोई खास नहीं, एक दोस्त कच्चा पक्का सा, एक झूठ है आधा सच्चा सा, कभी हंसने का कभी रोने का, बस एक बहाना अच्छा सा, राहों का ऐसा साथी है जो दूर नहीं और पास नहीं, कोई तुमसे पूछे कौन है एनाटॉमी, तो कह देना कोई खास नहीं, तो कह देना कोई खास नहीं. Thank you very much. Stay tuned with me. Any kind of doubt, beta, and this beautiful, amazing platform, you can ask. Thank you. So now I'm handovering the part to the our next part. Okay, next our respected faculty. Thank you, everybody.
So, hello everyone. Myself, Dr. Pooja, and I'm your physiology faculty. Let me know if I'm audible and visible to you guys. All right. So, yeah. Hello, Priyanshu. So I hope I'm audible. I'm just waiting for a minute because there is a lag between the YouTube and this Zoom session. So we will be starting in a minute, right? So just give me a thumbs up, just give me hello or something so that I can know that whether you are able to hear me or not. Right? So from my side, it's absolutely fine. All right. Audio, video, all good, right? So let's move on. All right. Thank you, Dr. Abhi, Kevin, Priyanshu. All right. So let's start with the general physiology session, right? So let me know that if you feel like the speed is too much or the speed I need to decrease, right? Whatever it is, just let me know because I'm able to see your comments over here. All right. So let's start with the very first question. Statement, there are two statements given. First statement A, the activated B lymphocyte will get proliferated and transformed into memory cell. Is that true? Let me know that. Statement B says the CD8 protein occurs in the surface of T cells. And which one? Which binds to MHC type 2 proteins. Which of the following is true? Actually, it is from immunity, and even if you know it is from +2, that means your 12th standard knowledge, if you can just gather it and you apply the concept, you will be able to solve this question. So let me know. Good evening, very good evening, Imran. Kripsi, okay. Banwar Singh, Priyanshu, Hasina. All right. Wonderful name. So, क्या आंसर लगाया है इसका? Yes, tell me. Is it true that activated B lymphocyte will get proliferated and transform into memory cell? Yes. First of all, they will be converted into plasma cell. Some of the B lymphocyte will be converted into plasma cell. What is the role of plasma cell? Can anybody tell me? Hanji, फटाफट से बताओ. With high energy, we are going to complete it. I will not be taking you your much of the time. Plasma cells. Plasma cells will be, they are specialized into formation of antibodies, your favorite antibodies. Yes. So, okay, wonderful, Priyanshu. I'm happy that you joined the class. All right. So, plasma cell are going to form the antibodies, isn't it? And they are going to be formed by the B lymphocyte itself. So, that is true. And some of them are going to form the memory cell. Why the memory cells are required? So that next time, if the same foreign antigen falls and come and try to attack our body, what will happen? These B lymphocyte will suddenly get activated by the memory cell. You will have the memory of that antigen, and your cells are going to form. The B lymphocytes are going to quickly form the plasma cell, convert into antibodies, right? So memory cell reduces the latent period. What is the latent period? The time when the bacteria or the foreign antigen enters and your activation of immunoglobulin or immunoglobulin when they get activated, that duration from the entrance of the bacteria till the activation of your immunoglobulin, be that IgM or be that IgG, right? So that period is known as latent period, right? So that latent period will be reduced. That means your immune system is going to react. It is going to respond quickly as compared to the first exposure or previous exposure, all thanks to memory cell, all thanks to memory cell, right? Yes, Dr. Abhi, excellent, excellent. So yes, it is true. Now, if you would have attended my class, my students will definitely be able to tell me the answer of this. I gave you one trick. CD8 protein occurs on the T cells. Yes, that is possible. But which binds to MHC2 protein, kya? No, I told you there are two types of MHC protein. First of all, tell me what is MHC? It is major histocompatibility complex. Histo का मतलब क्या होता है? What do you mean by histo? Histo means tissue, right? Histology. You study the tissues, right? Different kind of tissues. So that is nothing but histology. So major histocompatibility complex. That means it is the identity card of your cell. Whether it's your cell or it is some foreign antigen, you have to identify it, right? Otherwise, there is a probability that your own immune system will attack on your own cell, which is known as autoimmune disease. We don't want that, right? So that's why we gave a pretty identity card to our each and every cell, right? So that is known as MHC1 protein. But if I ask you, do we have MHC2 protein in the normal scenario? Yes. In our body, you have to have the MHC type 2 protein. Let's take a scenario like this. I usually give this example that if let's say a terrorist or some kind of criminal who is having the gun or some explosives. So do we have to have the explosive with our army person or our policeman? Yes, for their you can say fighting, we require to give them the guns or explosives also, right? So similarly, to identify, to match or to catch hold of that antigen, that is MHC type 2 protein, which is not in our cell body, regular tissues, right? To catch hold of that antigen, we require MHC2 protein, but it will be only present with the antigen presenting cell who are taking that antigen and presenting to our immune system, make the antibody against this. So they are kind of catching hold of it and presenting it to the immune system so that they can produce the antibodies, right? So only the guns and the explosives will be there with the army personnel or with the police, not to the general population, not with the general population, isn't it? So please remember that it is not true. It is not true. There are two types of protein. First is going to be MHC type 1 protein, and then there is MHC type 2 protein. MHC type 1 and MHC type 2 protein. MHC type 1 is going to have this cluster differentiation 8, and MHC 2 will be having cluster differentiation 4. Now, how to remember that? If you multiply it, the value should come, or the summation should come as 8, right? So 8 into 1, that is going to be 8, and 2 into 4 is also going to be 8, right? So remember like that, whatever you do, the multiplication factor, the multiplication result should come as 8, okay? So MHC type 1 will be giving you CD8, and MHC type 2 will be having the CD4, right? So what is the answer of the first question? Tell me, fatapat say. Yes. Is it this correct? No. So statement A is true, B is not true. So answer A is correct. Otherwise, A is correct. Both are not true, both are not false. So these cannot be the answers. I have, because I know you have a good visual memory. So for your visualization, I have this, which I have taken from the article. So you can see this. Nobody will ask you in the first year, but if you know that, your pathology is going to be way more easier, because anyhow you will be learning this into pathology next year, right? So see over here, what is the difference between MHC1 and MHC2? Are they different? Yes, they're very similar, but there are some different differentiation factors that we are going to discuss. Now see over here, there are four molecules. There are four globulin molecules which are going to be there. That is alpha 1, alpha 2, alpha 3, and beta 2 microglobulin, which is going to be there in the MHC1. But if you check in the MHC2, what do you have? Alpha 1 and alpha 2 on the same side, and beta 1 and beta 2 on the other side. That means you have the beta 1 instead of alpha 3 in this. Okay. And this over here, this alpha 1 and beta 1, they are going to make the cradle in which your antigen is going to fit. All right. Over here, if I talk about this one, the alpha 1 and alpha 2 is going to make a cradle in which the antigen is going to fit. All right. So that's how we get to know, our immune system get to know that whether it is my own body cell or it is the foreign antigen against which I have to make the antibodies. For now, just remember that this groove, that is what is written over here, the charge characteristic of the groove, right? Depending on which type of globulin is forming that cradle, right? Depending on that, we are going to decide whether it is MHC1 or MHC2. If it is attached with the peptide, this orange color peptide, if it is attached with the MHC2, that means we have to form the antibody against it, isn't it? So that is the one difference that I wanted to tell. Yes, there are many differences. And if you want, you can write it. If you're writing it, I'll be so damn happy, right? And if you don't want to write right now, because I know that there are classes going on, right? And you can write it later. So here is the thing. You can take a snapshot of it, right? So distribution. What about distribution? On all the nucleated cell, we are going to have this MHC type 1. What is the full form of it? Major histocompatibility complex. Basically, identity card. In the bracket, you can write identity card, isn't it? So rule of it. Yes, Dr. Abhi. Wonderful, wonderful. Thank you, Ayush. So antigen presenting cell, APC. In the short form, you're going to call it as APC. It's a standard short form. Standard means as for the hemoglobin, you write HB. It's a standard short form for the hemoglobin. So usually we call it as APC. If it is written as APC, understand that this is nothing but the antigen presenting cell. right? So we know that antigen binding cleft, the cradle is going to be made up of alpha 1 and alpha 2. Over here, it should not be 12, it should be 2. Alpha 1 and alpha 2 domains, right, which are going to form the one cradle. And if both the ones are coming, so 1 plus 1, that becomes 2. That is alpha 1 and beta 1, that becomes 2. All right. So please remember that. Now, binding site of T co-receptor. T cells are going to have receptors. We will see that in the diagram next time, right? I have in the next slide. So CD8 is going to bind to alpha 3 region, and CD4 over here is going to bind to beta 2 region. Again, alpha 3 and beta 2. If I show you over here, see, alpha 3 here and beta 2 over here, right? They are on the opposite side. So please remember that. Okay, so CD molecules are going to have the different binding site, different binding co-receptor regions are going to be different. All right, so that is also there. Size of the peptide binding cleft accommodates the peptide up to 8 to 11 residues. Peptide made up of amino acid, isn't it? And over here, it can accommodate a bigger peptide, that is 13 to 25 residues or even more, right? So cradle of this MHC2 is bigger. 1 smaller, 2 bigger. 2 is bigger than 1, right? So that's how you can remember. Now, there are some nomenclatures which are going to be there, such as HLA1, that is a genetic nomenclature. HLA-A, HLA-B and C, it's easy for 1. And a first standard mein hum easy kaam karte hain, all right? And then remember that, just give me a minute. All right, so yeah, so then we are going to have this nomenclature over here, that is DR, DQ, and DP. All right, so DR, DQ, DP, that is going to be there in case of the MHC type 2. All right, so that being said, let's move on. Just have that visual memory over here. Antigen presenting cell, I told you, they are going to present the antigen. If some foreign antigen, nasty bacteria, virus come into your body, of course, it is going to cause the phagocytosis. What is the first line defense? Don't rush into the answer. Just hear me out. There are two types of questions. What is the first line defense in your body? And what is the first line defense in the blood? Give me the answer. Let's say first question is, what is the first line of defense in the body? And what is the first line defense in the blood? All right. Two different questions, two different answers. Okay. So tell me, I'll be waiting for your options. All right. Then viral infected cells, if let's say my own cell is there, right, which got infected by the virus, okay, but it is my own cell, right? So it won't be having MHC2. Understand that. It is not bound to the antigen presenting cell. It is my own cell inside which I'm having the virus. Now what to do? We have to sacrifice that cell, right? That cell will sacrifice himself. You must have seen the army personnel, they sacrifice themselves, right, to protect the India or protect our country, right? So the cell also does the same. Why? Because if it doesn't sacrifice himself, the neighboring area, the neighboring tissues, the neighboring cells are also going to get infected, and it is going to cause infection, which is going to be much at a higher level, right? So now what happens? Since this is my cell which got infected because of the virus or the bacteria, of course it is going to give me the CD8. All right. But again, the T cell, CD8 T cells are going to bind over here, and CD4 T cells are going to bind to binding to the MHC type 2 protein. If it is MHC type 2, I told you CD4 are going to bind there, right? And these are the co-receptor. I told you that co-receptors are going to bind to either alpha 3 or beta 2, right? So here we are going to have the alpha 3 since it is MHC type 1, and over here we are going to have beta 2, right, to which it is going to bind and identify whether it is my cell or not. Okay, but yes, when it is infected, what is going to happen? There will be projection of this MHC2 which will be different, and hence it will also activate the antibody production against that cell if it is infected. All right, so I was waiting for the answer. Devansh, absolutely correct. All the barriers, the answer for the first one was barriers, such as the wax in your ear or the skin which acts as a barrier, plus you eat street food, like the winter vacation is going on in most of the colleges over here also. So you eat street food, right? Pani puri, bhel puri and whatnot, right? You do not know what type of water he has been using, that chef has been using, isn't it? So it can have lots of bacteria or viruses, but we don't usually get sick. Why? Because first of all, we are Indians. We do have good immunity built up since the beginning or since the childhood because we eat street foods. What happens is the antibody recognize it, and before the infection occurs, it is going to kill the bacteria. But there is one more protection, that is your highly acidic pH in the stomach, 1.2 to 2, which is very acidic, right? So please remember that is going to kill most of the bacteria, except there is something known as H. pylori you should be reading about. Okay, we will be talking at about this H. pylori into the GI system. All right, not right now. So that is the nasty bacteria which can survive there at very high pH. All right, so barriers are going to be the first line of defense in the body. But if I ask you first line of defense in the blood, it is going to be neutrophils. It is going to be neutrophils. All right. So there are two different questions, two different answers. All right. If the barrier is not given, then of course the answer will be neutrophil. All right. So let's move on. Let's move on to the second question. I hope this question is clear. All right. Chalo, आगे बढ़े. All right. Let's move on to the second question. The osmotically most active intracellular cation. First of all, tell me, what do you mean by cation? What do you mean by anion? Cation mein T is coming now. So it looks like positive. So please remember, if it is looking like positive, that means we are talking about the ions which are positively charged. The ions which are positively charged, right? And if I talk about anions, right? Anion mein N is coming. So please remember, they are negatively charged. Negatively charged molecules are going to be there. So please remember, they are asking about cation. Now understand, proteins are also more inside the cell, right? The second hint over here was intracellular. Intracellular. Yes, the proteins are, osmotically active, but they are not cations. They are anions. And since they have high molecular weight, right, and low, different sizes are lower, right? So that's why they mainly contribute to oncotic pressure and not to the osmotic pressure. All right. Then comes the magnesium and potassium. Both are higher in ICF as compared to ECF. All right. Sodium is more in ECF, right? In my classes, I told you that when we developed from the unicellular organism, of course, we evolved from the unicellular organism and now we are multicellular organism, right? So that's how the evolution occurred. And when we evolved as the unicellular organism, that first time evolved into the seawater, and seawater was salty water. So we evolved into, our cell evolved into salty water. Till now, till date, we require salty environment outside of the cell. Why? Because we evolved as per so. So do we have salty environment in our body? Yes. In our body, cell ka environment is going to be your extracellular fluid, mainly your interstitial fluid. Is it salty? Yes, because the sodium and chloride mix that salt. All right. So let's make a 2 by 2 table. Let's write cation over here and anion over here. Let's write on the top, let's write the ICF and ECF. Nanotech. Yes. So answer do fatafat. Yes, most of you are absolutely correct. Cation and anion. So ICF में कौन सा होता है? ICF में you have most abundant cation, that is going to be potassium, followed by magnesium, and you have the anion, that is phosphates and protein. Phosphate and proteins. Proteins are charged? Yes, they are negatively charged. Remember that, okay? And talking about ECF, extracellular, I told you that salt is going to be there. Mainly the salt is made up of sodium and chloride. All right, so salt is going to be higher outside, and that's why our cell live in the salty environment. We can see that, right? With that, we are going to have calcium and bicarbonate higher outside of the cell, isn't it? So please remember, this is the chart, very important. Now, if they ask most abundant cation into the ICF, that answer is going to be potassium, right? Both are PYQ. I'm mentioning you the previous year question of the NEET PG, right? Can be asked as a university question in your university, right? So remember, most abundant cation into the ICF is going to be potassium. But if they ask most abundant, if they ask most abundant divalent cation, then the answer is going to be magnesium. Then the answer is going to be magnesium, right? So please remember this chart. If you even remember this chart, if I ask you, these two are more inside the cell, but osmotically most active कौन है इनमें से? Because since the potassium is osmotically active and it is in the abundance, so I'm going to mark as potassium. I'm going to mark it as potassium. Is magnesium osmotically active? Yes, but much lesser as compared to sodium chloride and potassium. Okay, so and plus sodium chloride we don't have in the intracellular fluid. So my best answer over here is going to be potassium and potassium. All right, so please remember that. Okay, you have to choose most appropriate answers there. Okay, hope you got that correct also. Wonderful, wonderful, Rajdeep, Mohammed, Afzal, right? Abhishek, wonderful. Right. So the third question, let's move on to the third question. All of the following proteins are known as molecular motors. Motors which are going to have the motion, right? Motion means to move. So they're going to move as a cargoes, isn't it? Because of their involvement in the intracellular trafficking. Except पूछा है जी, ध्यान से देखो. There is question which is asked, which is except पूछा है, so answer क्या होगा? If you remember, kinesin, dynein, myosin, keratin. Tell me, even if you know the advertisement which is going on nowadays, right? Especially in the shampoos and whatnot, in the even the skin products, you have collagen and keratin. So, is the keratin going to be acting as the motor, molecular motor, or it is going to be there as a connective tissue in the skin and appendages like hair and nails and all? Yes, it is not going to be there as the molecular motor. Rather, it will either act as the cytokeratin, which is going to be acting as a intermediate filament, right? Or it is going to act as a epithelial cell connection. All right. So yes, wonderful, wonderful. The answer is absolutely correct, Abhishek and Muhammad Afzal. I'm very happy that you're giving the answers correct. So see over here, this is the diagram which I have taken from Genome, and this is how the question came in the NEET PG. All right. So exoplasmic flow. What do you mean by exoplasm? What do you mean by cytoplasm? The plasma is nothing but the medium. You require medium for everything. So inside the cell, you have a medium. Why you require medium? Because inside your cell, you have the factory. What is the factory? Nucleus, mitochondria, Golgi apparatus. Then you have rough endoplasmic reticulum, smooth endoplasmic reticulum, and whatnot. So all of them are going to either produce proteins, lipids, neurotransmitter, all these things, or ATP, let's say, right? So they all are going to act as a factory. So when the metabolism is going on inside the cell, require a medium, and the plasma is going to be providing us that medium. So if the plasma is present inside the cell, we are going to call it as cytoplasm. If the plasma membrane or not the membrane, if the plasma or that medium is present inside the axon, we are going to call it as exoplasm. Easy, right? See over here. If I say that this is the cell body, you know the neuron ka structure. This is one neuron, right? This is the cell body of the neuron, and mind you, all the factory material just I mentioned right now, nucleus, Golgi apparatus, rough endoplasmic reticulum, smooth endoplasmic reticulum, vesicles, the mitochondria, all of them are going to be present into the cell body, which is known as soma, right? And then we are going to have the long process attached with the soma. That is, we are going to call it as axon, all right? And at the end of axon, we are going to have these axon terminals. Terminates means that is going to end there, right? So that is going to be having one important property of exocytosis. So vesicles are what? Vesicles are basically the storage bodies, okay? You do have the, you can say the nani ka potli or dadi ka potli you must have, right? So piggy bank basically, in which you store the money. These vesicles are going to store whatever is produced by the soma, right? Neurotransmitter ho gaya or nerve growth factor ho gaya. So let's talk about neurotransmitter, okay? Neurotransmitter, most of them are produced at the soma. Reason being, because the factory is there in the soma, all right? So they are going to be produced in the soma, except like acetylcholine, which can be produced in the axon terminal also, all right? But though they are produced in the soma, they are going to be exocytosed. That means they will be secreted from the terminal. So what is the problem? The problem is the axon is there in between. I have to transport that vesicle towards the axon terminal. So how this is going to occur? This is going to occur with the cargoes, right? So remember, if I have to get, let's say I have to transport, I have to travel from point A to point B, right? How I'm going to transport? Let's say I choose railway, okay? So there is going to be railway track. Okay, I require a track first and I require railway cargoes, that is railway ka dabba I require, okay? So the track will be formed from the protein molecule which is known as tubulin. It looks like a tubule, microtubule. This tubule is very, very small, teeny tiny. So that's why we call it as microtubule, which is made up of, hang on, the name we don't have to remember since it looks like a tubule, right? We are going to call that protein as tubulin. There are three types of tubulin, alpha, beta, gamma. Mainly it is going to be made up of alpha and beta. Why not gamma? Gamma helps in the cell division, not in the transport. For now, just remember, this is the track on which my railway is going to, you can say, run, all right? So this track is made up of the tubulin protein, and if I zoom at it, this particular molecule, it looks like this, okay? So this is the cargo, which you can see over here. I'll just highlight it. If you can see this zigzag point over here, so this is nothing but the cargo. How this happens? These are coiled two structures, right? One is going to move forward and then another is going to coil back again and go forward, okay? So that's how they move. That's how they move, okay? One by one, like a steps, right? So these are their footsteps. One will go forward, then again this will go forward. Then first one will come forward, second will follow that, all right? That's how they're going to move, and that's why they're known as molecular motor. And what is this? They are carrying the cargoes. It can be nerve growth factor, it can be neurotransmitter, or it can be any protein. Sometimes they carry the mitochondria also towards the axon terminal, okay? Now, what you can see that this arrow is showing that the transport is going from the soma towards the axon terminal. If the substance is going from the soma towards the axon terminal in this direction, I will be calling this as, once again, I will be calling this as the anterograde transport. I will be calling it as anterograde, means in the straight direction towards the axon terminal. So if it is going towards the axon terminal, we're going to call it as the anterograde transport. But what if it is going to come back in a reverse manner from the axon terminal towards the soma? If it is coming towards the soma, then I'll be calling it as retrograde. If it is coming in the reverse direction, I will be calling it as retrograde transport. Now, if I talk about this particular protein, this was given as A, and they ask you, what is the A? Wonderful Ikigai. Oh, nice name that. Abhishek, and again, Ikigai, right? So Khan also giving, Subhi also giving the answer. Wonderful. So they have asked that identify A and B. So A, please remember, it is, इसको भी कुछ नाम दे देते हैं. So the name is kinesin and myosin. Kinesin, and there are various types of myosin, particularly type 1 and type 5. They are going to help us out. They won't ask you that. Just remember kinesin and myosin. These are the two types of protein which causes this anterograde transport, isn't it? But if I am talking about the reverse transport, which is coming from the axon terminal towards the soma, I will be calling it as retrograde transport. Now, I understand that anterograde, I require it because most of the neurotransmitter are formed there. Nerve growth factors are formed in the soma. So I require them. But why I require retrograde transport? Please remember, body is the best example of economy, right? Just say you must have the mom at your house, right? She doesn't throw anything which is old or which is just reusable back again, right? So similarly, the body also do not throw the material which can be reused back. So our body recycles it, right? Some vesicles have the neurotransmitter which didn't get exocytosed, right? So they will be recycled back. Or even if the vesicle is almost empty, we can at least reuse or recycle, remodify, modulate that vesicle, right? And form something different, okay? So that is going to be recycled back, or let's say nerve growth factor or whatever is left over, that will be recycled, right? So recycling ke liye we are going to require the retrograde transport, isn't it? So that is there. Now, different type of, you can see the shapes are different, isn't it? This is different and this molecule is different. Now, there is one clinical applied aspect over here. What is the applied aspect? What happens is, when the retrograde transport occurs, there are some toxins and there are some viruses. Can you tell me the name which are going to get hold of this molecule which is causing the retrograde transport and reach to the soma? And then they cause disease. But even if they got into the axon terminal, can't they proliferate? No. For that, they require protein, they require energy, they require the, if they're viruses, they require the, the access of RNA and DNA, right? Which is there inside my factory, that is nothing but the soma, isn't it? So now I have to go, or the toxins or the viruses have to get access towards the of the soma, isn't it? So they have to go towards the soma or towards my factory, and they take the help of this. Basically, they get adhered to this protein, and this is going to cause the neurological diseases which we don't usually have the cure of, such as, you must have heard of it. You must have heard of it. That is rabies, herpes, tetanus, and polio. Yes, we can give the vaccines of it, which is prophylaxis. Hone se pehle. Precaution is better than cure, right? So you are taking a precaution via giving the vaccines. But remember that if you have the patient of this disease, you cannot cure it completely. All right. So please remember, it is very, very dangerous. Patient will die because of these diseases and toxin. And the protein which is going to help the patient to die, that's how we can remember it. It is known as dynin. So please remember, the one which helps to die, that is dynin, which is going to cause the retrograde transport. So anterograde, kinesin, myosin, and retrograde, which is going to help the person to die or patient to die with the help of rabies, herpes, tetanus, polio. Of course, that's how we are going to remember. Otherwise, it is important for the recycling of the leftovers. All right. So you can remember. So if you want another mnemonic, you can remember my kind. Okay. What is my kind? Myosin. If you want to remember what are the names of the molecular motor, myosin, kinesin, and D for dynin, my kind. भगवान के लिए इतना याद रख लीजिएगा, ठीक है? आगे बढ़े. I hope you understood this, है ना? And I hope and I wish you remember that. All right. Let's move on to the next question. समझ में आया? Right? Yes, Devansh, you're absolutely correct. You're absolutely correct. Next, Abhishek also. Wonderful. So which of the following contributes least to the osmolarity of the plasma? Least to the osmolarity पूछा है. Osmolarity. What do you mean by osmolality and osmolarity? There is a small difference, right? Osmolality is better than the osmolarity. What is osmolarity? Osmolarity is nothing but the osmoles per osmoles of solute per liter of the solution. So osmolarity is per liter. And osmolality अगर मैंने पूछा तो there are two changes that you need to do. Lality. Two changes that you need to do. First thing is you need to change the osmolality. It is nothing but solutes or osmol. Let's take osmoles per kg of solvent. It is not solution, mind you. It's just the solvent. Okay, per kg of the solvent. So kilograms, or you can remember, if there are two L's, there is no spot for another L, so it cannot be liter. all right? Or you can remember that kilo mein L aata hai, so like that, kilogram is going to be there and kg of solvent, all right? It's just that osmolality is better. Why? Because more or less these are dependent on the osmol. It's just that it does not change. The osmolality will not change because of the temperature, but osmolarity will change because solvent is going to expand and that is going to increase the solution, all right? So that is going to be better. The osmolality is better, but usually we take the osmolarity. Anyways, but they have asked least, contributes least to the osmolality of the plasma. Sodium, does it contribute? Yes. More, something is holding on to the water that is going to be giving me the osmolality, that will be contributing to the osmolarity. Yes, the sodium, glucose, they hold on to the water, so they are going to be important for me. Urea, yes, urea is also osmotically active, but it is ineffective. क्या बोल गई मैं? अभी लिख देती हूँ. So urea is, yes, it is osmotically active, but it diffuses freely. Diffusion is active process or passive process? Tell me fatafat se. Diffusion is active process or passive process? Muhammad Afzal, yes, it is going to be important. Okay, it is important for osmolarity, but they have asked least contribution. Okay, so diffusion की वजह से क्या होता है? It is ineffective after some time. It is ineffective after some time, right? So if you give urea to someone, of course, what is going to happen? First of all, it is going to hold on to the water, but it is going to give, let's say you have given it IV, right? आपने plasma में दिया है, IV दिया है. What is going to happen? It will go in the interstitial fluid, then it will cross the cell membrane and it is going to go into the intracellular fluid also, unless and until the equilibrium has been achieved. So after some time, same amount of water will be there in the ICF, same amount of water will be there in the ECF. So basically, it will not be having much of the effect. So after some time, it becomes ineffective. बिना काम का रह जाता है. All right. Please remember that. Now talking about proteins. Protein also hold on to the water, but remember that this is going to be, again, it is going to be contributing to the least amount of it. Why? Because please remember that the proteins are going to be, yes, they are present in the abundance, right? But they are going to have low molecular weight. All of the protein, not only albumin, all of the protein, they usually have the low molecular weight. Okay, and because of that, what is going to happen? They are going to contribute it to the lesser, you can say, least contribution will be there of the proteins. But they hold on to the water, I told you just now. But please remember, they attract the water. Okay, so they will be the ones which are going to be responsible for oncotic pressure. Osmotic pressure is different, oncotic pressure is different. Please remember, the basic difference is you require osmol, mainly the charged particles, right? Mainly the charged particles. Yes, the proteins are charged, but they are going to have the higher, you can say, radius, right? So they are larger one, big molecules. That means if I take 1 liter of water, and if I add bigger molecules, they will be lesser in the water. On the other hand, if I take 1 liter of water, same amount of water, but if I add teeny tiny particles, more particles can come into that water. All right. So please remember that. And that's how it is going to, this will, you can say, you can use your imagination, and the osmol, the number of osmol I can add into, per that solution or that per kg of solvent, that is going to lead to the osmolarity, right? So what are the factors which can, you can say, change the osmolarity, and what are the factors which are going to change the osmolality? Let's see. First of all, concentration of the solutes. Concentration, not the amount. It's a concentration. In per liter of water, how much you are having the particular osmoles, right? Volume of solvent. If you increase the solvent, whatever solutes were there, you are not changing the solutes over here. If you keep the solute same and you add more solvent, it is going to get diluted. If it is going to get diluted, lesser amount of solutes will be there per unit of solvent. right? So it is going to be indirectly proportional to the volume of solvent. That means it is directly proportional to the volume of solutes, right? So type of solute, if it is osmotically active particle, what is going to happen? And if it does not diffuse like urea, it will cause or it will contribute to the osmolarity, right? Ionization, of course. Let's say you gave salt, that is NaCl, but as soon as you add the salt into the water, what is going to happen? The salt dissolves, right? Dissolve means it is going to get dissociated into Na plus and Cl minus. So those became two different molecules. So I don't have just one molecule of NaCl, but I have two osmoles of Na plus and Cl minus. That means I have more solutes, isn't it? So whomsoever is going to dissociate very nicely, right? Whichever is going to be water soluble, which dissolve properly, that is going to increase the osmolarity. Membrane permeability, if it is less permeable, then it is going to be, you can say impermeable, then it will give me the more osmolarity. Why? Because yes, Abhishek, Rajdev, Devansh, and Ayush, you guys are absolutely correct. Diffusion is a passive process. We'll come on to that. Now, as you guys told me about the urea, right? That urea is diffusible, but I don't have diffusible molecule, let's say like sodium and chloride. So they will stay there and they will attract more and more water. Okay, so that is there. So they are going to be effective osmolarity because of the impermeable ones. Because if something is permeable, after some time, not immediately, but after some time, it will equalize and it will not have much of the effect of the osmolarity. Temperature, slight effect. Not all articles agree with that, but yes, temperature also can expand the volume of the solvent and that can alter the osmolarity indirectly. That means if you increase the temperature, osmolarity can decrease. All right. Talking about oncotic, this you have to remember. Even if someone woke you up from the deep sleep, है ना? आज बहुत अच्छा लगा आपको anatomy, physiology, biochemistry, you understood it very well and you went to a sleep and somebody woke you up from the deep sleep and asked you which is the factor which is responsible for oncotic pressure, your answer should be protein. That is critical. You cannot forget it, right? You can call it as osmotic pressure, but colloid osmotic pressure. Colloid का मतलब ही होता है due to the proteins. Okay, so colloid osmotic pressure, it is mainly because of the plasma protein. Okay, it hold on to the water and this is none other than your plasma protein. Okay, why it is important to have the oncotic pressure? There are two types of Starling forces that you're going to read in the general physiology. You must have read already. What are the two types? First is oncotic pressure. Second is hydrostatic pressure. I told you hydrostatic pressure is the pushing pressure, isn't it? It pushes the water away. And what about oncotic pressure? Oncotic pressure holds on to the water. So if you have more oncotic pressure, or let's say you have balanced oncotic and hydrostatic pressure, if you have oncotic pressure balanced or normal or higher, it will drag the water. Let's say you're having capillary oncotic pressure higher, it is going to drag the water from the interstitial fluid into the plasma, right? Or into the blood vessel. If suppose this is the blood vessel, if you have lesser protein production, let's say malnutrition is there, or the patient got severe burn, second degree burn or higher burn, right? Or he's losing the proteins from the GI tract or kidney, proteinuria is there. What is going to happen? Less protein means less holding on pressure. That means less oncotic pressure, less pulling pressure, less water will be hold on into the blood vessel. So more water will be pushed. The hydrostatic pressure will dominate and more water will be pushed into the interstitial fluid. And extra fluid in the or accumulation of excessive fluid in the interstitial fluid, that is or interstitial space, is known as edema. The patient will land up into edema. And that's why this is critical to have the normal oncotic pressure. Otherwise, the patient can land up into edema. Remember that. Okay. Now, what are the things which are going to contribute to the oncotic pressure? Of course, plasma protein, and the main protein is going to be albumin. We know that, right? Capillary permeability. If the capillary permeability increases because of the less protein, what is going to happen? Of course, the oncotic pressure is decreased. So the patient will land up into edema, right? When this occurs, this can occur in the inflammation or sepsis, which is basically the infection when it's spread throughout the body via the blood. We call it as sepsis in the simpler term, right? Hydration status, if overhydration is there, the plasma protein will be diluted. So oncotic pressure will be relatively less because the concentration of the protein will be relatively less because you added more water, the proteins got diluted, right? Hemodilution, hemoconcentration, the same mechanism as hydration, which is going to be there. And even the acid-base balance, changes in the pH can affect the structure of the protein, right? Highly acidic pH can damage some protein. It causes denaturation. Even if highest temperature, like more than 42 degrees Celsius, what is going to happen? There will be something known as denaturation of protein. Protein is going to break down automatically. They cannot hold on to their structure, right? There will be configurational changes, there will be denaturation, and of course, there will be no oncotic pressure. So patient will again land up into the edema, all right? So I hope you remember that. The answer of this question is going to be, of course, protein. It is mainly dependent, the oncotic pressure is mainly dependent on the protein, not the osmotic pressure, right? Please remember that, okay? Not the osmolarity, it's, right? Let's move on to the next one. All of the following statement about the azurophilic granules, हाँ जी बताइए, of the neutrophils are correct except, चलो फटाफट से आंसर बताओ. I'm waiting for your answer. Yes. Hydrostatic pressure hates the water. Okay. Oncotic pressure loves the water. I will remember that. Abhishek Raj, thank you. So, except पूछा है, so you have to find out wrong answer. पहली चीज याद रखो. When you go to the LKG and UKG, which is the first alphabet which you are going to learn, that is going to be A. So please remember, A comes first. So it is primary granule and not the secondary granule. Does it contain myeloperoxidase? Yes. So if the peroxidase is present, peroxidase test is going to be positive or negative? It is going to be positive. Does it contain cathepsin? Yes, it contains cathepsin also. Please remember, even if you know it is the first alphabet, so primary granule. Second alphabet, S for second, S for specific granules. Okay, so that's how we can easily remember that. Okay, so please remember, it is not the secondary granule, and we have to identify the except, which is the wrong statement over here. So I'm going to mark it as option A. थोड़ा सा discuss कर लेते हैं. Let's discuss it a little bit so that you will remember it forever. Okay, so azurophilic granule, I told you A for the first alphabet is going to be A. So A over here, please remember, it is going to be primary granule. S for specific, S for secondary. So remember, S for S, specific granules are secondary granules, and gel comes the gelatinase. They are going to be the tertiary molecule. All right. There are some secretory granules also present, which are not going to come under primary, secondary, or tertiary. Separate. So we are going to call them as secretory vesicles only. Okay. Now, please remember, of course, you go to the first standard first, right? So who are going to be formed first? Of course, the azurophilic granules are formed first, and they are the largest one. If you can see the size over here, big size, all right? So they are going to be the largest one. So please remember, myeloperoxidase, neutrophil elastase, proteinase 3, cathepsin G, which is there, azirosidin, of course, the name is there. So aziro, right? You can remember that. Alpha defensin, lysozymes, and the BPI is also there. Okay, there are some names. You at least remember 3 to 4 names which are must. Myeloperoxidase is must. Azirosidin is must because the name matches with that. Cathepsin, proteinase, and neutrophil elastase. You have to remember these. Coming to the specific ones, NGAL, lactoferrin, cathelicidin, and the lysozyme. Lysozyme can be there in the azurophilic, can be there in the specific, right? Gelatinase may also, you're going to have the lysozyme, and there are some other secretory molecules which are going to have the albumin as well as the azirosidin. All right. Now, what are the questions that they are going to ask? They can ask you about the size. So you remember that it narrows down as you go towards the secretory, and that's how I mentioned this. This is the bigger box. This is the smaller. This is the smaller one, even smaller, and this is the smallest one. Okay. Now, please remember, when the formation occur, you must have heard of the leucopoiesis. In the leucopoiesis, you have that major pluripotent cell, multipotent cell, then it will be converted into committed cell, right? Then it will convert into promyelocyte. myelocyte, then metamyelocyte, promyelo, myelo, metamyelo, and then it is going to go towards the leukocyte, whichever is formed. We are talking about neutrophils, so we are going to talk about it. All right. So when it is getting differentiated, the committed cell towards promyelo, myelo, metamyelo, in that differentiation process, we are going to form this granules inside the neutrophil. Okay, so during the differentiation, these are formed. And who is going to be formed first? Of course, your favorite acidophilic granules are going to be formed first. Okay, now when I talk about degranulation, when the bacteria comes and actually these are the killer enzymes, isn't it? Not for my own cell, for the foreign antigen, foreign bacteria or viruses, right? So I'm going to degranulate them. So the enzymes will come out and, land up onto that bacteria, and it is going to do the killing of it, isn't it? So please remember, over here, when I talk about granulation, it is easier to degranulate. It is easier to secrete the smaller granules, all right? So secretory granules will be degranulated first. Bigger will take time, right? So that is going to be the degranulation of acidophilic granules are going to occur at the last. Okay, please remember that in one slide you will remember everything. Okay, so you can draw this in your notebook, right? So again, a colorful picture. So see over here, there are many granules, right? So there are 4 granules which are going to be there, right? Let's say the bacteria comes or pathogen comes, which is going to cause pathology, right? There are different methods by which my neutrophil is going to start killing the bacteria, viruses, pathogen, antigen, whatever you call it as. Okay. Now, if the molecule is smaller, what they are going to do? They are going to engulf that pathogen inside the neutrophil, combine it with the lysosome and causing the blast of it. All right. So see over here, when they eat the bacteria, it looks as if they're eating the bacteria and killing it via forming the phagolysosome. First of all, they take the bacteria inside, right? It looks as if they're eating the bacteria or pathogen, that is called as eating is known as phago. Okay, so they are going to form phagosome. When that phagosome combines with the lysosome, it will be called as phagolysosome, or it will be called as maturation of this phagosome. All right. So first of all, phagocytosis will be there. Phagolysosome will be formed, will be matured into phagolysosome. फिर क्या चीज है? Release the enzyme, kill the pathogen. All right. Now, if that is not possible, what I'm going to do? As soon as I see the neutrophils, see the bacteria, what they're going to do? They're going to hold the bacteria there, right? And they're going to degranulate. The granules are going to come towards the edges and they're going to secrete their enzymes onto the bacteria so that that pathogen gets killed, right? If the bacteria is so large that even the degranulation might not work, then what we are going to do? We are going to set a trap for it. Right? How? We are going to form a meshwork. So if you can see over here, there's something known as neutrophil extracellular trap. As you know, it is by the neutrophil. It is intracellular or extracellular? Extracellular trap. Why we require extracellular trap? Because it's a very big molecule. I cannot take it inside. The neutrophils cannot take it inside. And via degranulation, it is not going to die. All right. So they are going to have some other method. They adapt to some other method and they find out the solution for that. These are nothing but the DNA fibers equipped. That means, of course, they're going to have DNA in them with the granules cargo. That means they are going to have the cargo which are going to contain, those cargos are going to contain those explosives which are going to blast your pathogens. All right. So please remember, this is the bacteria, or let's say this is the pathogen. What is going to happen? Of course, I'm going to have the cargos. So I'm going to release as soon as the bacteria, pathogen, whatever it is there, which is going to get trapped into that trap, which we have set extracellularly. Of course, then we are going to cause the granulation. We are going to attach that granules and release all these secretions there. Multiple granules will be attached and hence killing the pathogen. All right. So there are 3 methods. You can mention it. I promise you, your examiner is going to be way more happier that you know all these things also. All right. So please remember, this is how the neutrophil adapts. So now, most recently, in the last 2 years, this Ficolin 1 granule is also discovered. It is yet to come in your books, so I didn't mention it before, but if you want to write, excellent. Okay, so formation we know that the formation is going to occur during neutrophil differentiation. We know that, right? Packaging, pre-packaging, modification, everything is going to occur during that time. Also, it is going to get pre-packed, and then it is going to set up into the neutrophil. All right. Now, how the release or degranulation occurs? First, you're going to activate the neutrophil. For that, we require the chemotaxis and all these processes, right? You need a pathogen in your body, all right? That is going to activate the neutrophil. Neutrophil is activated. The contents are going to be secretory granules, which are going to be released. Once the activated neutrophil is there, they're going to release the granules, right? And gelatinase granules, pehle to secretory granules, then gelatinase. I told you, na, it is going to easy to release the smaller granule, then the bigger one, then the bigger, and then the biggest one. That is azerophilic, right? We are going to come back from the secretory to gelatinase to specific to azerophilic, all right? So azerophilic will be released last. It is produced first, but it is released last, all right? So please remember what they have to do. They have to kill the bacteria. That's all. All right. Let's move on to the next question. Which of the following will be synthesized by smooth endoplasmic reticulum, all right? It is for everyone, Aman. All right, it is for everyone. Which of the following will be synthesized by smooth endoplasmic reticulum? हाँ जी, फटाफट से बताओ क्या करता है smooth endoplasmic reticulum? Now, there are two types of reticulum. If I look into the microscope and I see the smooth lining of the cell, right? That is one scenario. I'm going to call it as endoplasmic reticulum. If I see under the microscope and I see something like this, let's say this is endoplasmic reticulum, right? And onto which the ribosomes are studded onto the cell wall. And if I zoom it in, I'm going to have a rough, you can say, structure, which I can see in the microscope, right? Because of these ribosomes which are studded onto it. So kaise dikhega iska cell wall? The cell wall will look something like this, isn't it? It will be rough in structure. It will not be smooth. So if the ribosomes are studded onto the endoplasmic reticulum, I'm going to call it as rough endoplasmic reticulum. And what is the role of ribosome? Wherever you are going to see the ribosome, the only function that they do, they're going to produce the proteins. So please remember, protein production is the role of the ribosome. Wherever they go, they are going to be causing the protein production. Okay, so please remember, ribosomes are important for the protein production. So RER contains the ribosome. Of course, they are going to produce the RER, also going to produce the proteins, isn't it? But if I talk about smooth endoplasmic reticulum, which does not contain these ribosomes, of course, it must be for some different, you can say, different substance production. And what is it for? It is for smooth endoplasmic reticulum. If it is smooth endoplasmic reticulum, it is for the lipid production, as you guessed correctly. All right. So yes, it is for the lipid production. It is not for the protein production. Protein ke liye you require ribosomes. Okay. So is it going to produce carbohydrate? No. It is going to produce nucleic acid. Kya? No. It is going to happen in the nucleus, not in the Golgi apparatus or endoplasmic reticulum. So it's going to produce protein. Kya? No. It is going to produce lipid, because we are talking about the smooth endoplasmic reticulum. आयुष पहले आपने आंसर सही बताया था, आई थिंक. Okay, I was asking about ribosome, so you get that. All right. Yes, Abhishek Raj, absolutely correct. Okay, Megha Keshri. All right, wonderful. So the answer over here is lipid. थोड़ा सा एक sneak peek कर लेते हैं into the cell physiology. All right. So this is your cell, not your cell, anybody's cell. Let's say any mammal cell. So this here we are going to have the nucleus, which is the key, genetic key, right? All the genetic coding is going to occur from here, right? Your DNA is going to be there. Now, if I talk about this, what do you think? Which endoplasmic reticulum it is? Of course, you can see the ribosomes which are studded onto it. Of course, it is going to be the rough endoplasmic reticulum. It is going to produce protein. But look over here. This teeny tiny area is going to have the smooth endoplasmic reticulum, which is going to produce lipid. And if I ask you, steroids are lipid or proteins, bacho? Steroids, NEET PG 2023 question, which of the following is produced by smooth endoplasmic reticulum? Options were amino acid, eicosanoid, proteins, and steroids. Amino acid, eicosanoids, proteins, and steroids. Please remember, amino acid are going to form polypeptide. Polypeptide ultimately, when it is going to group together, it is going to form protein. So it is not formed by the smooth endoplasmic reticulum. Eicosanoids also formed by the amino acid. It is not be formed by the smooth endoplasmic reticulum. On the other hand, steroids, it looks like the oil looks like oil, right? So yes, it is lipid. Yes, it is lipid, thyroid, steroid, they are lipids, right? So please remember the steroid production is also going to occur with the help of smooth endoplasmic reticulum. So the answer was the steroid. Okay, easy peasy. If you know the concept, you will be able to solve the question, right? Wherever I teach, I tell them in the SGMC that you can solve any type of question, USMLE. If you know the concept, you can solve INI CET questions, right? So you should just have to have the concept, all right? Cytosol, I told you it is for the medium, right? Mitochondria, everybody knows it's a powerhouse of the cell. Energy production, you can slash write it as ATP, all right? Peroxisome, it is going to chop off the long fatty acid into smaller fatty acid. Basically, it is going to help you in the digestion in the GIT. But in the rest of the cell, what it is going to do? In the rest of the cell, oxygen, the excess of oxygen is also bad. Okay, it is going to produce something known as ROS, reactive oxygen species, which is going to kill your cell, all right, steadily and slowly, but it is going to be harmful for your cell. I always tell in the class that nothing more or in the deficiency less is, good for the body. Everything should be in the normal range. Okay, so peroxisomes are also important. Do you require oxygen? Yes, but excess of oxygen is going to be bad. All right, so that's why we have to control this excess of oxygen, and that's why you give this antioxidants, isn't it? But remember, the peroxisome also help us out to cut down these reactive oxygen species. So don't worry, breathe smart. Okay, Golgi apparatus, as we know, G for Golgi and G for packaging. It is going to pack the things whichever are, right. So you're going to check whether your cell is going to have the checking points, right? It will be checked whether it protein formed properly or not, lipid is formed properly or not, and then it will be packed and then it will be sent to the destination. All right. So packaging will be done by the Golgi apparatus. There are different types of cytoskeleton. Skeleton means whichever is going to support, right? And this supporting to the cell. So we are going to call it as cytoskeleton. All right. And we do have Singer-Nicholson model of bilipid layer, phospholipid layer, cell membrane. All right. So this is what is there. Mitochondria, energy production, Golgi, packaging, sorting, packaging. Please remember that. Okay. Endoplasmic reticulum, depending on whether it is smooth endoplasmic reticulum or rough endoplasmic reticulum, they're going to either produce the lipid or the protein. Vacuoles, they are store bodies. We know that. Lysosomes, they are going to act as a suicidal bombs, right? If the virus has infected my own cell, it is going to kill that cell itself. All right. Peroxisome, degradation of hydrogen peroxide, which is also one of the reactive oxygen species. All right. Chalo. One question for you guys, that the free ribosome, if they are present in the soma, free ribosomes, if they are present in the soma of the neuron, that means body of the neuron, what it will be called as? It is discovered by one scientist. He gave his own name. So tell me फटाफट से क्या बोला जा सकता है इसको? This is the question, extra question, bonus question for you guys. Okay. I'm moving on to the next question so that you can give me the answer, because there is a slight lag into YouTube and this Zoom. All right. Most of the sodium ion in the body, it should be ion. Okay. Sodium in the body is present in. Is it present in bone? No. In the bone, you have something known as hydroxyapatite. Hydroxyapatite is made up of calcium plus phosphate plus water. Calcium, phosphate plus water. 3 minus. Calcium, phosphate plus water. अभिषेक, पहले का आंसर तो बेटा, फर्स्ट का आंसर क्या आएगा? what it will be called as. सोमा में अगर free ribosome होगा तो क्या बोलोगे इसको? पहले आंसर दो इसका. All right. So bone में you're going to have these three things, which is going to form the hydroxyapatite and some osteochondrocyte cell. Osteo means bone wale cells. They are going to also get trapped into it. Okay. So sodium has nothing to do with the bone. It is mainly by your calcium, phosphate, and the water. Okay. Calcium and phosphate, when they meet with the water, they are going to form the paste and they get deposited onto the bone. Simple, right? जैसे हम cement में mix करते हैं, right? So it is kind of that, right? So of course, the bone is not going to be the answer because most of the sodium in the body, it is not going to be there. ICF or ECF? It is going to be in the ECF. We just have discussed in the ICF, you're going to have the potassium and magnesium. Potassium and magnesium. So ICF cannot be the answer. I told you in the ECF, we still require salty environment for our cell to be nourished and to evolve and do its function, right? So please remember, it is not going to be. Wonderful, Ashish. Ayush Sharma, agar aap samne hote, I would have given you the chocolates. All right. And Devej Singh. All right. So yes, you guys are absolutely, absolutely correct. It is none other than Mrs. Granule. Mrs. Granule. All right. So it is none other than Mrs. Granule. He has discovered it, right? So we are going to call it as Mrs. Granule. Coming back to it. Now, you have two kindly similar answers, plasma and ECF. What should be your answer? Remember, the ECF is made up of interstitial fluid plus plasma. Who is going to have more contribution, whose name is longer. Longer name is interstitial fluid, right? Very long name. So longer name is of interstitial fluid. It is going to contribute 75% to that of the ECF and only 25% contribution will be there of the plasma. So please remember, if I take the contribution, the interstitial fluid is more. If I ask you the concentration of the sodium is going to be it is going to be equal, more or less in the ECF. The concentration will be same because that is going to give the osmolarity and the osmolarity is going to be same in the ECF, that is in the plasma also, in the interstitial fluid also, and in the ECF it is mainly because of the sodium and chloride. Okay, so it is going to be same there. But if I talk about volume, if I talk about content, both the things are different. Mind you, concentration, that means you take it in the percentage, right? If I talk about content or volume, you take the amount of it. All right. So of course, if I'm having more amount of interstitial fluid, I'll be having more sodium ions there, isn't it? So I'm going to choose ECF as the better option. If they would have not given as ECF, let's say something else, they would have given all of the above, none of the above, then I would have gone with the plasma. Okay. But you have the most appropriate answer in front of you. That is nothing but the ECF. Wonderful, Anurag. Wonderful, Abhishek. Okay. So it is going to be ECF. So I have a small chart for made for you, right? So volume, if I consider the 70 kg man, it is going to be around 10.5 liters of interstitial fluid, of course, which is much, much more than the plasma. 3 times that of the plasma, isn't it? So if I take the concentration, that is per liter, 1 liter of plasma, 1 liter of interstitial fluid, same amount of sodium is going to be there. But in reality, I have 10.5 liters of interstitial fluid. So if I take the amount of it, it is going to be again 3 times more that of the plasma. In the plasma, I'm going to have 490 millimole. In the interstitial fluid, I'm going to have 3 times more. So the better answer over here is going to be ECF, which contain both interstitial fluid also as well as plasma also. All right. So the answer over here, the best answer over here is going to be ECF. All right, G. Next question. The larvicidal major basic protein, MBP, major basic protein is secreted mainly from which of these cells? So I'll give you the answer and then we will go forward. Major basic protein, basic proteins, basic granules are there in the eosinophil, which attracts the acidic stain. Please remember the homosexual wala rule we have discovered in the human beings. It is not natural. Nature says the opposite attracts and similar repels each other. All right, same charges repel each other. So same over here, eosinophils contain the basic granules right? They attract the acidic stain. Remember that. So यहाँ पर basic protein की बात हो रही है. Yes, it is going to be eosinophil. It is not going to be neutro or basophil. Okay. So I have a little chart for you if you can go through that quickly. Eosinophilic granule, of course, it is going to be in the eosinophilic, basophilic granules, and we have seen acidophilic, specific, and tertiary gelatinase wala granules, and some secretory granules are also going to be there in the neutrophil. Talking about MBP, major basic protein. Again, if you want, you can take a screenshot of it. Major basic protein will be there in the eosinophil. All right, eosinophilic cationic protein, of course, naam diya hota to that you would have got that completely. Peroxidase also there. Histaminase is going to be there. Histamine kahan par hota hai? Histamine will be produced by basophil. So whenever the allergy occurs, histamine will be released, and to cover or to control the allergic reaction, the eosinophils will come there. But when we are going to do the test, basophil will do its work, causes the allergy, and run away from there, isn't it? And when you do the blood test, you will be found that the eosinophils are high. Eosinophils are not the culprits. They are the ones which are going to trying to control the allergy. All right. So please remember, who is going to be the culprit of allergic reaction symptoms? It is going to be the histamine, which is released from the basophil, who is going to try to control it. It will be controlled by the, yes, they modulate the allergic reaction, they control it, right? They break down the histaminase. Yes, biochemistry, Ankur sir will tell you all about ACEs, all about the enzymes, right? Wait for that. So that is going to be there. And anaphylaxis means if the response is there throughout the body, allergic reaction is severe, we call it as anaphylaxis. Okay, it is going to promote the inflammation, immune response is going to be there, which can be higher too, right? Nasty cell, basophil. All right, it is going to contain heparin, leukotrienes, right? Of course, it's a leukocyte, so whatever cytokines will be released from this, it will be called as leukotrienes, and cytokines are also there, such as IL-4. All right, we have talked about the neutrophil, so let's not talk about it again. And larvicidal action, of course, it is going to be because of the eosinophil. And I have, if you notice, I have done the color coding also. We do have pinkish or brick red color of eosinophil granule. I couldn't find that color. So there is a red or purple color is there, basophil, basic color, basic stain it is going to take. That's why we call it as basophil. But they contain acidic granules. Remember that. And neutrophil, which are going to contain both the granules. All right. Wonderful, wonderful. Macrophages, yes, they are also going to contain acid hydrolases, lysozymes. These are the main ones, okay? And reactive oxygen species, which are going to be helpful in the respiratory burst. If you want to read on it, just go and read on it. Respiratory burst, which helps in the killing of the bacteria, okay, which is harmful. We use that against the bacteria. All right, smart cells, isn't it? Phagocytosis of the pathogens and debris, antigen-presenting cells, they also have this. All right. Chalo, next, second last question. The lipid bilayer is most permeable to. Now, this is a controversial question, but if I have to choose the best answer amongst these, I'm going to go with the urea. Okay. Please remember, lipid bilayer will not allow, in any case, it will not allow the polar molecule, okay, charged molecule. Urea, U for urea, U for uncharged. Is it charged, positively charged, negatively charged? No charge, okay? So it is uncharged molecule, which is going to be, yes, it is diffusible without any channel, without any transporter. Also, it can get diffused. It can transport across the cell membrane very, very easily because of its teeny tiny, you can say, structure. Water, it requires some channels. If I ask you channels, acting as a transporter, yes, but if they're always open, there are some gates which are always open, you do not require any energy to open them, right? So the channels for the water ke liye we call it as aqua, and the pores are going to be there, so we call it as aquaporins. Aquaporins are going to be there for the water, you can say, transport. Some aquaporins are always open, and that's why some aquaporins, if the channels are always open, of course, the water is going to diffuse across the membrane according to its concentration gradient. But it requires the channel. Remember, always. Both are diffusible. Both are diffusible But if I have to choose one, I'll be choosing urea, because without channel also, without transporter also, it can diffuse, right? Because it's a teeny tiny molecule, diffusible molecule. Glucose, it's a polar molecule. You cannot. It's a water soluble molecule. Water and lipid, they do not go hand in hand. Water does not like lipid, and the lipid does not like water, isn't it? So please remember, they do not go hand in hand. We have talked about sodium also. Sodium is a charged molecule, right? It's a polar molecule, and it also gets dissolved into the water. That means it is water soluble. And we just now discussed water and lipid does not go hand in hand. They will never ever go hand in hand. So please remember, there are some points about the urea. So urea is, teeny tiny molecule, and it is relatively lipophilic. It loves the lipid, all right? So lipid also treat the urea as friend and allows it inside or outside of the cell membrane wherever the concentration gradient is lesser, from high concentration to low concentration. So it can transport without a transporter also, but at places where we require more transportation of the urea, we have to have the urea transporter. UT1, UTA, UTB, UTA will be divided into UTA1, 2, and B1, 2, like that. Okay. So what are the, you can say, properties on which it is the diffusion is dependent on? First of all, it's lipid solubility, right? If it is lipid soluble, it can go, and we know that lipophilic molecule, urea is slightly lipophilic, yes. What about water? The name itself, water, na? Water and lipid does not go hand in hand. That's why urea again becomes a better answer. All right. Teeny tiny molecule, only 60 Dalton, easily cross the cell membrane. Okay. And concentration gradient, of course, diffusion, as you guys told me, it's a passive process. Passive process always along the concentration gradient, from high concentration to low concentration. As simple as that. Okay. All right. Chalo. Wonderful, wonderful. Ayush Sharma, water does diffuse, but the better answer is going to be it requires the channels. At times, it will not be open. The channels might be closed, might be open. You require a channel. So better answer is going to be urea. It is not at all lipophilic. You require channel for that, okay, for the water. It can diffuse if the channels, there are some channels which are aquaporin 1 and aquaporin 3. They are constitutively, means continuously, all the time they are open. It can diffuse across the channel, but you have urea in the option. If except urea, let's say, change the option. If I change the option here, if I change the option, except urea, I have written over, let's say, chloride, then the answer will be water. Okay, I hope you got that. But I have urea in the option, so I'll go with the urea. According to option, you have to choose the most appropriate answer, right? Remember that. चलिए आगे बढ़ते हैं. The protein claudin. The protein claudin is associated with which of these transmembrane protein? Desmosome, tight junction, gap junction, hemidesmosome. Question is for 1 crore rupees. हाँ जी, आंसर बताइए फटाफट. Ikigai, you're absolutely correct. Just give it with the confidence. You're absolutely correct. Okay. So it is none other than your tight junction. It is none other than the tight junction. All right. How to remember this? What is this transmembrane protein, and what is this claudin and other proteins? Let's see that. Now we are going to talk about intercellular junction. There are two neighboring cells. They want to communicate with each other, or they don't like each other. So they put barricade in between. Either ways, it is the junction between two different cells. So we are going to call it as intercellular. If that would have been inside the cell only from point A to point B of the same cell, we would have called it as intracellular. But since this is between two cells, we are going to call it as intercellular junctions, right? There are three main junctions that we are going to talk about. The rest of them, they won't ask the question much, right? But we will discuss that too. Now, see over here. Gap junction. First thing first, gap junction. If I zoom it in this diagram, what can you see? See, there are three cells. This is cell number 1, cell number 2, cell number 3, isn't it? And see, if I show that this is the cell 2 and cell 3, let's say, right? So if I zoom this area in and I show you, so this is going to be, let's say, one cell or second cell. Okay, so if I take, let's say, this and zoom it in, how this is going to look like? This is going to look like exactly like this. Okay. And what can you see over here? There are some proteins, half protein from here, half protein from here. They are forming the shortcut of into the cell membrane. Okay. So let's say this is the ICF of cell 1 and this is the ICF of cell 2. Let's say I have to make the transport of polar molecule. Now, there are two ways, right? Let's say I have to go in the next building. I have two ways. What are the two ways? First, I'm living right now on the second floor. So I have to go to the ground floor, go to the next building, take the staircase and go to the neighboring building, right? Or I have another option. I drill it over here. I'll make one door from my side. I ask them to make a one door and make a shortcut in between, isn't it? So who is going to reach first? Which way I'm going to reach first? Of course, the shortcut, isn't it? So see over here, sodium also has two options. Find out its own channel, go outside, travel along, find out another channel of the sodium of the cell membrane 2 and get into the ICF. Or it can get into the ICF of the another cell via these shortcuts. That is nothing but the connexin proteins, right? So if I zoom it out, this structure cross sectional आपको ऊपर से दिखाया. If I show you it superficially, right, this is going to look something like this. All right, the half protein is known as connexin protein. And how many such connexin molecules are there? Count with me. It is 1, 2, 3, 4, 5, 6. 6 connexin molecules, subunits. They are going to come together and they are going to form connexon. Thank God. No fancy different name, right? Connexon. How to remember? Remember, they're connecting the ICF of two cells, right? So that's how we are going to remember. They are connecting two cells. So connexin, how many subunits? 6 such subunits are going to come together and they're going to form connexon, right? 6 subunit of cell membrane number 1, 6 subunits of cell membrane number 2, okay? So that is how the connexon will be formed. What is the benefit? Quick transport. It's a shortcut now. So very quick transport. So let's assume you're talking about the ventricular myocyte or you're talking about the urinary bladder, right? What is going to happen? Let's say ventricle, right? Ventricle is what? It is the muscle, okay? It's a blood pumping machine, right? So it is going to have thousands and thousands of muscle cells. But when the time of systole comes, is it going to contract like this? One cell will contract, then the another, then the another, then the another. No, the whole ventricle contracts simultaneously at the same time. How this is possible? This is possible thanks to these gap junction. Because of the gap junction, one cell get depolarized first. As soon as it gets depolarized, it is going to make the depolarization of neighboring cell possible in a very quick manner, right? Why? Because the sodium is going to travel very quickly via these gap junction, right? So the whole ventricular myocyte, those thousands and thousands of muscle cells, they act as a one single unit. We call it as syncytium. What is syncytium? Everything. These thousands and thousands of muscle cells, they act as a one single unit. They act as a one single unit. And that is we call it as syncytium. When you go for urination, when you go for, susu ke liye jate ho, what is going to happen in your urinary bladder? Of course, urinary bladder is also made up of smooth muscle, isn't it? Your detrusor muscle. What is going to happen? One muscle will contract one time, then the next. No, the pressure will not build up and susu will never come out. So for that, you require to contract all the muscles simultaneously so that the pressure will build up and you can go for the washroom, isn't it? You can do your voiding. So please remember the power of one single unit. It can build up a lot of pressure, right? Might be developed right now. So please remember it is present in the heart, that is cardiomyocyte. It can be present in the urinary bladder. It can be present in the gallbladder, vessels, right? Wherever you require one single unit, the muscles should act as a one single unit. You are going to attach a gap junction between them, right? Smooth muscle, let's say the blood vessels, right? And in the intestine also you have this for the peristalsis basically, and gallbladder. Wherever you require to contract them simultaneously, you're going to give them the gap junction. All right. Let's talk about exactly opposite to this, that is tight junction. Okay, let's say with lot of hard work, the kidney has trying to excrete the waste material or harmful substances which I do not require any longer in my blood. What if they trickle back into my blood? I will not like it now. My kidney is doing such a hard work to make them go out of my body, and they are coming. They are finding out some shortcuts, and if this, coming back into my blood, the whole kidney work is wasted. I don't want that. So what I'm going to do, I'm going to put the barricades in between the cell. All right. So there are two types of transport. Remember, let's say this is cell A. Let's say this is cell B, and these are the cell membrane of those cells. So I'm going to have the junction between them, which are going to tightly pack. They will not allow any substance to cross through. If the substance is crossing through like this, through and through out of the cell, across the cell, if it is going across the cell, you call it as trans. Trans literally means across, and it is going across the cell. So you're going to call it as transcellular transport. Transcellular transport. And if something is going from the periphery, not across the cell, but it is going from the periphery, then you're going to call it as the paracellular transport. Okay, so if it is not going through the cell, it is going sideways from the cell, periphery of the cell. If it is going from the periphery, you're going to call it as P for P, paracellular transport. Do you want paracellular transport, or you don't want it in the kidney or in the VIP organ? You eat anything, right? Let's say street food, you ate that. Can you allow everything to go into your brain? No, it's a VIP organ, right? You cannot allow everything and anything to go in your brain, in your CSF. So you have to have the barricades, right? So you want to prevent the paracellular transport. And thankfully for that, we are going to have these barricades available. Let's say some politician is going, or some IAS, IPS, some sort of official vehicle is going. For that, they have police put the barricades. Okay, what is going to happen on the normal roads? Of course, there will be traffic jam. Either they are going to close the road. Now, listen over here carefully. The last thing I'm telling you, either they're going to close the road, right, or they're going to partially close the road or occlude the road. We can say they're going to occlude the road or they're going to close the road, because of which there will be traffic jam on the road. So remember, the same way the proteins are going to be occludin protein, barricades are there, then there will be occludin, Cloudin, close karna, Cloudin protein, or there will be a jam, which is going to be there, traffic jam. So please remember, what is this traffic jam? This is not a traffic jam. This is the junctional adhesional molecule, which is going to be there. Jam kya hai? Junctional adhesional molecule. So these three things are going to be helping us out to form the molecules. What is the benefit of tight junction? It prevents, please write down, it prevents the paracellular transport. It prevents the paracellular transport. Mainly कहाँ पर होता है? It is present in the BBB. What is BBB? Blood-brain barrier, and in the nephron. Blood-brain barrier in the nephron also. All right. So please remember that. Let's move on to the third one. Very simple. Adherent junction. Adherent junction, which is going to be there, right? As the name suggests, adhere karna means to stick together. If you stick something together, the bonding is going to be very, very strong, right? If you attach one cell to another cell, of course, what is going to happen to the strength of the tissue? It is going to increase, right? So that is why they are there. Adherence means they stick that cell together, they anchor the cell together, and they're going to improve the strength, or they increase the strength of the tissue overall. So you can see the anchoring proteins are there. They are nothing but your adherent junctions, right? And they have asked already the question on the cadherin. The name itself contains adherin. So please remember, these molecules, that is actin, catenin, and cadherin, these are the three protein molecules which are going to form the adherent junction. Adherent junction, sticking together, increases the strength. Nothing special, all right? Chalo, आगे बढ़ते हैं. The last one, that is desmosome and hemidesmosome. If half desmosome of one cell and half desmosome of another cell, they come together, half and half makes it full, all right? So we're going to call it as desmosome, but only half desmosome is there, which is attaching to the basement membrane. I'm not having another cell. I'm attaching it to the basement membrane. Only half of the desmosome is sufficient. So that's why I'm going to call it as half desmosome. So hemidesmosome. All right. Both of them are more or less are formed of the same proteins. What are the proteins? Desmo. Desmo is going to form desmo. What is desmo? I'll tell you in a minute. Desmoglein is the protein and desmocolin is the protein. So desmoglein, desmocolin are going to form the desmosome or hemidesmosome. Please remember that. All right. So please remember, here they have asked about the claudin, which is going to be the tight junction. The clinical aspect, let's take one more minute. Clinical aspect of it. What is the clinical aspect? Remember that the cholera is going to attack, the Vibrio cholerae virus is going to attack on this tight junction, and they are going to form the rice gruel stool, which is going to lead to diarrhea. All right, which is going to be the occludin protein they majorly attack onto, right? And that is going to lead to diarrhea. So a little progress each day add up to a big result. All right. So thank you very much. I hope you like the session. If you want to connect to me, you can connect on the Cerebellum platform, or I have the ID, the Insta ID Physio by Pooja, right? You can join me there also, or you can join me on the Telegram group, official group of the Cerebellum, right? You just write @PN or Dr. Pooja Nigade. You can join me there on the Cerebellum platform, or you can message me personally, right? Physio by Pooja, physio_by_Pooja is my Instagram ID. You can ask the doubt, whichever you are having there, right? Any type of doubt which you have in the MBBS life, all right? We'll take the session on it also, all right? So I'll hand over to Ankur sir. You're going to have the, be ready to have fun with Ankur sir. All right.
Good evening,
So are you
ma'am.
there?
Thank you, ma'am.
Welcome, sir. So I'll just stop sharing it so that you can share it.
Good evening, friends. So we are going to discuss 10 questions, and which are really good questions. We'll try to understand the basic concept of general biochemistry. The first question: in glycolysis, the first committed step is catalyzed by. You all know that the rate limiting enzyme of glycolysis, rate limiting enzyme, is phosphofructokinase. This enzyme catalyzes committed step. Now we understand what does it mean. We are in fed state. Suppose we are taking diet regularly at regular time interval. I took food. And you know that 60-70% of our diet, approximately 60-70% of our diet is made up of carbohydrate. Means majority of our diet is carbohydrate. So carbohydrate is having multiple function in our body. One function of carbohydrate is production of energy. You all know. So we will see what are the function of carbohydrate, which is the major constituent of diet. As we take carbohydrate or diet, means that is fed state. That is fed state 2 to 4 hours after taking diet or food, whatever you say. Now, as you take carbohydrate, blood glucose increases. It is ingested, digested, absorbed. So, prototype of carbohydrate we all know, that is glucose. So, glucose increases in blood. That glucose go to pancreas. That extra glucose go to pancreas and release insulin. release insulin. Whatever I am telling you, this flow chart is base of biochemistry. If you will understand this, multiple question can be solved by this flow chart or flow diagram. Yes. So you all know a question is asked that very important factor which release insulin is glucose, blood glucose. So now I remember insulin as injection. Okay. So you will remember like this. Now I just told you that carbohydrate is having multiple function. One function is energy production, and that is done by glycolysis. So I take this glucose will enter glycolysis. In glycolysis, glucose is converted to glucose 6-phosphate by hexokinase. Hexokinase. This is the first step, irreversible step of glycolysis. Question is asked that in glycolysis, first irreversible step is catalyzed by hexokinase. Now this glucose 6-phosphate is converted to fructose 6-phosphate by reversible reaction by isomerase. You all know glucose and fructose are isomer. So name of enzyme is isomerase. Okay, I leave it. Fructose 6-phosphate is again converted to fructose 1,6 biphosphate by irreversible step. So till now I have told you two irreversible step. One is catalyzed by hexokinase, and second step, this is catalyzed by phosphofructokinase or phosphofructokinase 1. Now I will skip other steps and I will conclude the glycolysis by saying that glucose is having 6 carbon. A 6 carbon compound is converted to 2 molecules of 3 carbon compound pyruvate. Pyruvate, 3 carbon. This is aerobic glycolysis. I write here aerobic glycolysis. Question is asked that in aerobic glycolysis, net gain of ATP, net gain, not produce, net gain is 7 ATP. If you want to remember, you can easily remember how many letters in aerobic. 3, 4, 5, 6, 7 letters are there in aerobic word. So 7 ATP produced by aerobic or net gain. Better to say net gain 7 ATP. And 2 molecules of pyruvate are produced. And we said that phosphofructokinase is rate limiting enzyme. And this step is committed step of glycolysis. Committed step of glycolysis. Why we said it committed step? Because we found that if glucose is converted to glucose 6-phosphate, this glucose 6-phosphate has multiple fate. I am going to discuss. But if fructose 6-phosphate is converted to fructose 1,6 biphosphate, it means it has become Salman Khan. एक बार commitment कर लिया तो ये अपने आप की भी नहीं सुनेगा. Only and only glycolysis will occur. Now I explain. So I told you one aspect of carbohydrate metabolism, that is energy production, and that is done by glycolysis, and glucose molecule is converted to 2 molecules of pyruvate. Another function of carbohydrate or glucose is HMP shunt. What I said? HMP shunt. Another name for this is pentose phosphate pathway, PPP. Name itself tells you pentose phosphate pathway means by this pathway you produce pentose sugar, ribose sugar. Ribose sugar. You all know DNA, RNA are having pentose sugar. DNA is having deoxyribose sugar. RNA is having ribose sugar. So this ribose sugar can be produced by HMP shunt. So function of HMP shunt or pentose phosphate pathway is to produce pentose sugar, one function. Second function of HMP shunt is to produce NADPH. NADPH. Wherever you will find the word reductase, in many reactions you will find the word. Yes, it is also useful for January FMG, and actually we are going with the questions discussion and concept also, and you will find that so many questions will be covered by this flow chart, so definitely it would be useful. Okay. Yes, Chocoberry. Now, so I told you that one function was energy production, second function was to produce pentose sugar and NADPH. Function of NADPH is reduction. So wherever you want reduction, most of time, it's not a rule always, but most of time you will find NADPH. Okay. Now, if I ask you that carbohydrate, till now I have told you two functions. One is energy production by glycolysis. Second is HMP shunt. In this HMP shunt, the function is reduction and pentose sugar. How many ATP is produced by HMP shunt? Yes, please do comment. How many ATP is produced? Yes, 0 ATP. How many ATPs? 0 ATP produced. Why 0 ATP? Yes, simply it will say if you want to produce energy, go to glycolysis. I am not here to produce energy. I am here to produce pentose sugar and I am here to produce NADPH. Okay, so no ATP. Before going to this no ATP, I can say that here, glucose is converted to glucose 6-phosphate. Glucose is converted to glucose 6-phosphate, and the starting point of HMP shunt is glucose 6-phosphate. You can easily remember glucose is hexose sugar. HMP means H for hexose. Hexose, M for mono, P for phosphate. So glucose is hexose sugar. So glucose 6-phosphate is hexose monophosphate. So this is HMP shunt. Now listen carefully. I said that in glycolysis, this is irreversible step. This is irreversible step. This is irreversible step. Why I said this is committed step of glycolysis? Means if a glucose molecule thought that I should go for glycolysis and this glucose is converted to glucose 6-phosphate by enzyme hexokinase. Clear? Now this glucose 6-phosphate thought, no, I will not enter glycolysis. I will do HMP shunt. Yes, it can do. Yes, starting point of HMP shunt is glucose 6-phosphate. Means after this reaction, this product glucose 6-phosphate is not committed to glycolysis till now. It can opt another pathway. That's why it is not committed step. But if this reaction occurred, we said that if this step occurred, then all means phosphokinase, then only and only fate of this glucose molecule will be glycolysis. This is committed step. So first question. Yes, first question. In glycolysis, first committed step is catalyzed by phosphofructokinase. Pyruvate dehydrogenase is not enzyme of glycolysis. Pyruvate dehydrogenase is not enzyme of glycolysis. Glucokinase, yes, I will discuss shortly. Hexokinase, I told you that it catalyzes irreversible step. So it is regulatory enzyme. Regulatory enzyme. So remember, regulatory and rate limiting do two different terminology. If I say regulatory enzyme, it of glycolysis, one is hexokinase as option C. Second is phosphofructokinase, one, and third is pyruvate kinase. These are regulatory. Out of these three, the middle one is rate limiting enzyme. All these points are questions. So as we have 10 questions, so we will discuss only relevant thing. Will not go in depth the complete topic, but sufficient enough to solve multiple questions. Now, one more function of carbohydrate is that extra carbohydrate is converted to glycogen. Yes, glycogen. Glycogen is a polysaccharide made up of glucose. You all know glycogen is a polysaccharide made up of glucose, and the glycogen is stored in liver and muscle. So glycogen is stored in liver, and muscle. Question is asked that 2% of muscle weight is glycogen, while 10% of liver weight is glycogen. So if I ask you, percentage wise glycogen is more in, percentage wise glycogen is more in liver, but total muscle mass is much more than liver weight. That's why we say total glycogen is more in muscle than liver. Okay, so this is third function of carbohydrate, I can say. And here the rate limiting enzyme is name itself tells you we are synthesizing glycogen. So rate limiting enzyme is glycogen synthase. So for the time being, I can say in this flowchart why I have shown you this insulin here, why it is standing here. Yes, you all know that the main function of insulin, main function of insulin is to decrease blood glucose. So any reaction which decrease blood glucose is usually activated by insulin. So all these pathways means glycolysis, HMP shunt, glycogen synthesis, they are activated by insulin. Okay, so all rate limiting enzyme of all these three pathways are activated by insulin. So I have put insulin at this point just to tell you whatever I am going to tell you about this flowchart. All those steps are activated by insulin or all those pathways. Okay, and their rate limiting enzymes. Got the point? Now, we found that this pyruvate. Now again, I come to the energy production. Suppose this glycogen storage is full. As you know, 2% of muscle is glycogen, 10% of liver is glycogen. If glycogen storage is full, our requirement of pentose sugar and NADPH is fulfilled, then extra carbohydrate is entering glycolysis and more pyruvate is produced. Now pyruvate will be further oxidized in mitochondria. This is mitochondria. And you know, anything which goes into mitochondria that is oxidized. Yes, it is a, भट्टी जहां पे कोई भी गया खंडर है जहां पे मर जाते हैं. So pyruvate is also afraid that I should go inside or not. Then one friend came, that is HN. HN said, don't worry, I am here. Why do you fear? Both entered the mitochondria. So question is asked, pyruvate enter mitochondria with the help of HN import. So pyruvate enter mitochondria with the help of HN import. Now I take 2 molecules of pyruvate here. Pyruvate is having 3 carbon. This is converted to acetyl coenzyme. 2 carbon. A 3 carbon compound is converted to 2 carbon compound, and the name of enzyme is pyruvate dehydrogenase. Now, in fed state, I'm talking about fed state. Yes, we took food, carbohydrate, glucose is coming to pyruvate is coming to acetyl coenzyme. So you can say, what is the source of acetyl coenzyme in fed state? Most common source is pyruvate. Second question, I have changed the sequence of question. Who attempted the quiz? Yes, I have changed the sequence. The reason you can understand in a better way. Yes, acetyl coenzyme is common intermediate form from metabolism of carbohydrate, protein, and lipid catabolism. Yes, I have discussed till now about carbohydrate, but sometimes question is asked and you will find carbohydrate, lipid, protein. Ultimately, they produce acetyl coenzyme, and this acetyl coenzyme enter TCA cycle, and one acetyl coenzyme produce 10 ATP. This question is asked. So TCA cycle, one acetyl coenzyme produce 10 ATP. What about lipid and protein? We will discuss shortly. For the time being, I can show you that in fed state, main source of acetyl coenzyme is pyruvate. So second question, or question number 9, better to say, yes, main source is pyruvate. Clear? Yes. So now we come to this acetyl coenzyme. I just told you that acetyl coenzyme enter Krebs cycle. So I make here red color Krebs TCA cycle or Krebs cycle, TCA cycle. And when one acetyl coenzyme enter, it produce 10 ATP. I was telling you that I kept this insulin here, and I told you that all these pathways, whatever I am drawing, that is activated by insulin. If I ask you pyruvate dehydrogenase, you will say, sir, this is activated by insulin. Yes, insulin activate this. What about TCA cycle? Yes, any idea? Yes, TCA cycle. TCA cycle. Yes, you know that it is allosteric regulated. Means this is not regulated by insulin. TCA cycle says that I am the basic requirement for energy production. Yes, I will fulfill that. So I will not dependent on hormone. I will depend on local government. That if cell will require energy, cycle will start. If cell will not require energy, cycle will not go. So it is independent of insulin, no hormonal control. No hormonal control. Okay. I just told you when energy requirement of cell is fulfilled, then TCA cycle will stop. So you have taken so much of food, so much of carbohydrate, energy. Yes, again I'm repeating. Glycogen storage is full. Ribose requirement and NADPH requirement is fulfilled. Glycolysis, pyruvate dehydrogenase, TCA cycle, net gain 32 ATP, energy requirement of cell is fulfilled. Now what to do? Even now you are having some amount of carbohydrate left. You said, okay, we will convert this extra carbohydrate to fat and will store. That is माँ का प्यार जो अब तुम MBBS days में सब achieve कर लोगे. Yes, लड्डू. So carbohydrate, whenever you take carbohydrate, extra carbohydrate is converted to fat. Point it out. Question is asked that extra carbohydrate is converted to fat, but extra fat is not converted to carbohydrate. Okay. So how this extra carbohydrate is converted to fat? This acetyl coenzyme will be thrown out of mitochondria. When this energy requirement is fulfilled, it will be thrown out of mitochondria. Now, in cytosol, acetyl coenzyme will come. One more question I am solving here, that which pathway occur which compartment? This is mitochondria. I highlight with this color. This is mitochondria. Anything outside this is cytosol. You will remember like this. So if I ask you, yes, you can give me answer. If I ask you that glycogen synthesis occur in cytosol, HMP shunt occur in cytosol, yes, glycolysis occur in cytosol, pyruvate dehydrogenase reaction occur in mitochondria, TCA cycle occur in mitochondria, and all these steps pathways are activated by insulin except TCA cycle till now. Now we found that acetyl coenzyme came out of the mitochondria by citrate shuttle. By citrate shuttle. What is citrate shuttle? We will discuss later in other classes, other session. For the time being, yes, these acetyl coenzyme are present in cytosol now. We found that this acetyl coenzyme is converted to malonyl coenzyme by enzyme acetyl coenzyme carboxylase. Acetyl coenzyme carboxylase. Another name is malonyl coenzyme synthetase. Synthetase. So I can write short form AC or MS, acetyl coenzyme carboxylase or malonyl coenzyme synthetase. Question is asked that in lipid synthesis, what is the rate limiting enzyme? This is rate limiting enzyme of fatty acid synthesis. Fatty acid synthesis, and ultimately fatty acid is synthesized. This fatty acid means you converted, point it out, you converted extra carbohydrate to fat, fatty acid. This fatty acid will bind with glycerol to make triacyl glycerol, and which is accumulated in adipose tissue. Yes, motu ka pet. Yes. So in this way, you converted carbohydrate to fat. You converted carbohydrate to fat. Now, we found that this acetyl coenzyme can take part in cholesterol synthesis. Cholesterol synthesis. Cholesterol synthesis. Okay, so now I can say that cholesterol synthesis is not occurring in mitochondria. Fatty acid synthesis is not occurring in mitochondria. It is outside the mitochondria. So now all these pathway, all these pathway, all these pathway are activated by insulin. Yes, all these pathway. Here the name of enzyme is HMG coenzyme reductase, rate limiting enzyme. So all these rate limiting enzyme are activated by insulin. Clear? So now this is fad state I have discussed. So two function of acetyl coenzyme I have discussed. Acetyl coenzyme can be converted to cholesterol. Acetyl coenzyme can be converted to fatty acid. But acetyl coenzyme never converted to carbohydrate, never converted to glucose. So acetyl, I just told you, I write here. Carbohydrate can be converted to fat or fatty acid, but fat can't be converted to carbohydrate. Yes. Now, next question you can solve now. So acetyl coenzyme cannot take part in glucose synthesis. So now, yes, next question. Acetyl coenzyme can be converted into all of the following except I have just told you it can be converted to fatty acid, it can be converted to cholesterol. Yes, ketone what is left, I will discuss shortly, but it cannot be converted to glucose. Yes, means acetyl coenzyme cannot be converted to glucose, or you will remember like this: acetyl coenzyme is not substrate for gluconeogenesis. So frequently asked question, which are not substrate for gluconeogenesis? Simple, ketone bodies. Ketone bodies are never substrate for gluconeogenesis. First thing. Second, leucine and lysine. These are pure ketogenic amino acid. Pure ketogenic amino acid. Mnemonic for this is Lily, don't be silly, don't make glucose. So never substrate for gluconeogenesis, and acetyl is not substrate for gluconeogenesis, but very, very important question. Acetyl coenzyme is activator of gluconeogenesis. It is not substrate but activator of gluconeogenesis. So acetyl coenzyme can be converted to all of the following. It can be converted to ketone bodies. I will just show you. Yes, yes. Let me complete this question. For completion's sake, I am doing it here. Ketone body synthesis. This is mitochondria. It is occurring in mitochondria. Two acetyl coenzyme joint means starting point. I took two acetyl coenzyme to form acetyl coenzyme. At few places, you will find that the starting point of ketone body synthesis is acetoacetyl. Okay, so don't get confused. We will discuss with ketone bodies in detail. For the time being, yes, 2-acetyl coenzyme means acetoacetate is ketone body and ketone body synthesis occur in mitochondria, and you can say that acetyl coenzyme can be converted to ketone bodies but never glucose. So till now we have discussed only 3 questions, but it seems that we have covered only 3 questions, but more than these 3 you have covered so many questions. Let me show you animation. Yes, whenever you take food, blood glucose increases. I told you that extra glucose goes to pancreas and release insulin. Now, insulin, what is the function of insulin? I will write here. Insulin do incision, mnemonic. Insulin do incision of phosphate. Phosphate, or you can remember like this: insulin to insult of phosphate. And if you insult somebody, your girlfriend, boyfriend, definitely she or he would not remain with you. Husband thoda ye saath rahega. Yes, that's the reason. Yes, insulin mnemonic, it will help you to remember insulin insult or insulin do incision of phosphate. Yes, so insulin remove phosphate. Let's see. First, one function of glucose was glycogen synthesis. How did it happen? But rate limiting enzyme was glycogen synthase. I told you that insulin activate glycogen synthase. How it activate? It do dephosphorylation. Point. This is a question. Insulin do dephosphorylation means it remove phosphate group from glycogen synthase. Now it become active, and now this glucose is converted to glycogen, and this glycogen is stored in liver and muscle. G6PD, glucose 6 phosphate dehydrogenase goes. Yes, this is the rate limiting enzyme of HMP shunt. In this, glucose produce pentose sugar and NADPH. So glucose 6 phosphate produce NADPH and pentose sugar. Now, third function I told you that glycolysis rate limiting was phosphofructokinase. This phosphofructokinase again activated by dephosphorylation. Yes, insulin remove phosphate. This phosphofructokinase rate limiting enzyme of glycolysis is activated. Now this take glucose and convert to 2 molecules of pyruvate, net gain 7 ATP. Now this pyruvate enter the mitochondria with the help of HNS import. In mitochondria, pyruvate dehydrogenase again inhibited with phosphate. Insulin will come, insulin do incision, remove phosphate, and pyruvate dehydrogenase is active now. It convert 2 molecules of pyruvate to 2 molecules of acetyl coenzyme. These acetyl coenzyme enter Krebs cycle to produce 10 ATP. When energy requirement of cell is fulfilled, extra acetyl coenzyme are thrown out of the mitochondria, and I told you acetyl coenzyme is converted to malonyl coenzyme. First or rate limiting step, you can say, of fatty acid synthesis by malonyl coenzyme synthetase or acetyl coenzyme carboxylase, which is also inhibited state, which is also in inhibited state by phosphorylation. Now insulin do incision, remove phosphate, and now it become active, and it convert acetyl to malonyl coenzyme. Acetyl coenzyme join to form cholesterol also, and in this way this malonyl coenzyme convert to fatty acid, then triacylglycerol, and this is motor. Clear? Okay, so what is the purpose to tell so many things at the same place? Yes, now you can write here all these steps. Yes, I can write glycolysis, glycolysis, glycogen synthesis. Yes, HMP shunt, fatty acid synthesis, cholesterol synthesis. All these pathway are activated by insulin first. Their rate limiting enzyme, that is phosphofructokinase. Yes, Devansh, unfed state I will discuss shortly. Yes, the only purpose to justify the fourth option. Otherwise, that is fasting state. Unfed, you can say it is fasting or starvation. Okay, we will discuss shortly. So don't worry. At that time, it would be clear. So yes, glycogen synthesis, rate limiting enzyme, glycogen synthase, HMP shunt G6PD, fatty acid synthesis, malonyl coenzyme synthetase, acetyl coenzyme carboxylase, cholesterol synthesis, HMG coenzyme reductase. All these enzymes are activated by insulin, and all these enzyme, इसको मैं highlight कर देता हूँ, exceptions are always there, so just ignore this. All other enzymes are active in dephosphorylated state. Dephosphorylated state means they are active when they have no phosphate, and if phosphate is attached, they are inhibited. Okay. Okay, dear. So now you can easily tell me. Yes, one thing was left. Pyruvate dehydrogenase. Yes, pyruvate dehydrogenase. Just to complete it, pyruvate dehydrogenase is also activated by insulin, and this is also active in dephosphorylated state. All these question has been asked in your recent exam, and there is separate some small topic of phosphorylation, dephosphorylation of enzyme, short note in your prof exam. Okay, so we have covered this fed state. Now fasting state. Before fasting state, okay, this question, any doubt? Yes, we have completed 3 questions. Okay, now you can easily tell me fatty acid synthesis. Yes, can you give me answer? In this question, you can easily tell me, yes, I told you that anything outside this circle is cytosol. Yes, so if I ask you this fatty acid synthesis, it is occurring in mitochondria or not? No, it is not occurring in mitochondria. So I can solve this question by this flow chart only, that even if I don't remember about much about mitochondria, even then I can solve this fatty acid synthesis. Yes, is occurring in cytosol, and in cytosol at which place it is occurring, that will be discussed in fatty acid synthesis in detail. Yes, just remember this is occurring in cytosol. Other option, yes, beta oxidation occur in mitochondria. I told you mitochondria is a place where oxidation occur, everything is burnt, energy is produced. Beta oxidation occur in mitochondria. Mitochondria is having double stranded circular DNA. Double stranded circular DNA, and yes, it is replicated by gamma polymerase. Replicated by DNA replication occur in mitochondria, replicated by which polymerase? Gamma polymerase, mnemonic. Yes, when we will discuss polymerase, DNA polymerase, you will find alpha polymerase, beta polymerase, gamma, epsilon, delta, and you will find out of these only one polymerase is there, just which is having Ma. Which is having Ma, Ma for mitochondria, Ma for mitochondrial DNA synthesis. Mitochondrial DNA synthesis. There is also protein synthesis mechanism in mitochondria. You can understand like this: mitochondria in cell, eukaryotic cell. This mitochondria is originally it was prokaryote which entered the eukaryotic cell and they started living together. Now, yes, it is having its own translation mechanism. Protein synthesis means translation. It is also having DNA synthesis. So this is the way you can remember. Okay. So this question is covered. Now I come to fasting state. Yes, this is really, really important because so many questions, further discussion, I will take care of those things also. But for the time being, yes, in fasting state, I take here fasting state, glucose is not there. Yes, after some time, glucose decreases. It is utilized by different cells. So glucose decreases, insulin decreases, glucagon increases. So you will remember glucagon increases. Glucagon activate hormone sensitive lipase. I know you will forget it. That's why I make mnemonic here. Yes, insulin loves lipoprotein lipase. Insulin hates hormone sensitive lipase. So insulin loves means insulin activate lipoprotein lipase, which is present at blood vessel endothelium. We will discuss in detail with lipoproteins. This insulin hates hormone sensitive lipase means insulin inhibit hormone sensitive lipase, and you know insulin and glucagon two opposite hormone. So insulin inhibited, glucagon yes activated. And when hormone sensitive lipase is activated, this triacylglycerol will release fatty acid. This will release fatty acid. Hormone sensitive lipase will release fatty acid. Lipase means lipid will be cut and fatty acid will be released. Fatty acid will be released. So I am taking care of this thing, but at the same time, you know, yes, we found that liver is the main organ of metabolism. It is the responsibility of liver to maintain blood glucose. Why we want to maintain blood glucose? Because most vital organ brain utilize glucose in fed state, in fasting state, and also in starvation. Although brain can utilize ketone bodies in starvation, let me write here. Brain utilize glucose in fed state, glucose in fasting, and glucose in starvation. What is fasting and starvation? I'm going to describe starvation. Okay, and yes, glucose, and ketone bodies also in starvation. So it is the responsibility of liver to synthesize glucose for brain. So what liver do? Liver is already having glycogen stored in it. So what liver will do? Liver will break down glycogen to maintain blood glucose. So what is the purpose of this glycogen which is present in our liver? Liver is the main organ of metabolism. We know whenever we will take food, blood glucose will increase. That extra glucose will be converted to glycogen and will be stored in liver. In between meals, in fasting state, when blood glucose is being utilized by different cell, this liver glycogen will be gradually broken down to maintain blood glucose. And liver glycogen is sufficient. I can write here liver. Yes, yeah. Liver glycogen is sufficient to maintain blood glucose up to 16 to 18 hours. Chocolate boy, hi, dear. Yes, 16 to 18 hours. Means if I close you in a room and continue the session for 16 to 18 hours, there would be no hypoglycemia because our liver glycogen is sufficient to maintain blood glucose up to 16 to 18 hours. So 16 to 18 hours, liver, don't worry. But after 16 to 18, we sometimes say it is early fasting state. So fasting, we are discussing fasting state. Yes, fasting state. This is early fasting. Now up to 16 to 18 hours. Now prolonged fasting. Yes. Yes. Or simply you can remove this wording because it in different books you can get confused. Then up to 48 hours. इसको ऐसे रखते हैं. Up to 48 hours, what will happen? Liver will do gluconeogenesis. new glucose. It will synthesize new glucose. And at the same time, there would be beta oxidation of fatty acid. So up to 48 hours, this gluconeogenesis will more than beta oxidation of fatty acid. Okay. Now, beta oxidation of fatty acid, if I say beta oxidation of fatty acid, what happens in beta oxidation of fatty acid? Two carbon and 2 and 3 carbon, between 2 and 3 carbon cut is done, and this 2 carbon unit is released as acetyl coenzyme. And this acetyl coenzyme take part in ketone body synthesis. Okay. So if I ask you, ketone body synthesis occur in mitochondria. Gluconeogenesis start in mitochondria. Yes. But glycogenolysis, yes, I have taken it like this, means gluconeogenesis occur both in mitochondria and cytosol. Okay. Are you getting this point? So little bit idea would be sufficient. So again, I tell you that initially what will happen, glycogen will be contributing blood glucose. If glycogen is depleted, then gluconeogenesis will try to maintain blood glucose. At the same time, beta oxidation of fatty acid will be burned to produce energy. But after 48 hours, you will find that beta oxidation will be predominant. After 48 hours, beta oxidation more than gluconeogenesis, because gluconeogenesis will be exhausted. Okay. So all the substrate for gluconeogenesis will be exhausted. So liver will say, okay, plan C. Plan A was glycogen will be broken down to maintain blood glucose. Plan B was, okay, I will make glucose by synthesizing new glucose, gluconeogenesis. Plan C, okay, 48 hours, no food. Now we are going to understand, means liver understood that it's going to long journey. So better to start ketone body synthesis, because our brain synthesize ketone body, brain utilize, not synthesize. Yes, utilize ketone body in starvation. So now what happened, that beta oxidation acetyl coenzyme take part in ketone body synthesis. I told you that yes, acetyl coenzyme take part in ketone body synthesis. This acetyl coenzyme take part in ketone body synthesis. Okay, and I told you acetyl coenzyme is activator of gluconeogenesis. I don't discuss this part at this time because it will create confusion. For the time being, yes, we move to next question. Yes. So hope you have understood. Devansh, in fasting state, starvation, up to 16 to 18 hours, glucose will be maintained by glycogen. Then after that, there would be gluconeogenesis. Beta oxidation also started. Yes. After that, gluconeogenesis exhausted, beta oxidation continue, predominant, and produce ketone bodies. And ketone body synthesis and ketone body utilization both occur in mitochondria. Clear? Now we come to next question. So this question answer is B. Glycogen phosphorylase can be regulated by all of the following except glycogen synthesis and glycogenolysis. Let me tell you, these are two opposite pathway. If I join glucose molecule to form glycogen, this is glycogen synthase. This is glycogen synthase, rate limiting enzyme glycogen synthesis. It occurs in fat state. Yes, when we are having sufficient amount of glucose, extra carbohydrate is being converted to glycogen and is stored in liver and muscle. It is stored in liver and muscle. Now, we found that in a fasting state, glycogen will be broken down and the rate limiting enzyme is glycogen phosphorylase. It is just like Thanos. So, what happened? Let me show you how it works. Little bit idea, although we are not going in detail, but yes, Glycogen is present in liver. I told you up to 16 to 18 hours, liver glycogen will be broken down by glycogen phosphorylase. Glycogen phosphorylase is just like Thanos. How many stones were there? Yes, can you tell me? Yes, how many stones? If you have seen that movie, don't get confused. 5. Yes, it is. How many stones? 6 stones. Now it became powerful. Yes. So 6 stone mnemonic is 5. I have took 6 stones because yes, cofactor for glycogen phosphorylase vitamin B6 is cofactor for glycogen phosphorylase. Now what glycogen phosphorylase do? This convert glucose to glucose 1 phosphate, means glycogen is broken down. Yes, and it produces glucose 1 phosphate, then glucose 6 phosphate, and ultimately glucose is released in blood. So I can show you that this is glycogen phosphorylase, how it is activated. Cofactor, I told you vitamin B6, that is different thing. We found that epinephrine, they increase cyclic AMP. How you will remember? I make mnemonic insulin, glucagon. These are two opposite hormones, you all know. Glucagon, I remember bottle of glue. Bottle of glue. Okay. Insulin, do incision. Insulin, do incision. So suppose this is cyclic AMP. Suppose this is cyclic AMP. I make hypothetical structure. Now insulin will cut it. Insulin will cut it. So it will decrease cyclic AMP. Decrease cyclic AMP. But glucagon will add glue and will join it again. So glucagon increase cyclic AMP. So you will remember like this. This is really important mnemonic. Many time questions are asked. Long clinical scenario they will give, and you will find the answer by knowing this cyclic AMP only. Okay. So we found that cyclic AMP activate cyclic AMP dependent protein kinase A. Cyclic AMP dependent protein kinase A, and you all know, yes, protein kinase. Kinase transfer a phosphate group. Kinase transfer a phosphate group. So protein kinase will transfer a phosphate group here and will transfer a phosphate group here. And can you tell me, if I attach phosphate to glycogen synthase, it will be activated or inhibited? I told you, if you remember the animation, I showed you that glycogen phosphorylase, glycogen phosphorylase was, sorry, glycogen synthase was inhibited by phosphorylation. How we activated? How we activated? By cutting the phosphate, dephosphorylated state. So if you attach phosphate to glycogen synthase, it will be inhibited. So yes. So if phosphate is attached to glycogen synthase, it is inhibited. When phosphate is attached to glycogen phosphorylase, it is activated. Two opposite pathways are regulated in such a way, when one is activated, glycogenolysis is activated, glycogen synthesis is inhibited. Glycogen synthesis inhibited. Why it happen? Because this is liver. In this liver, we want to maintain blood glucose. We want to maintain blood glucose by glycogenolysis. Suppose you activated glycogen phosphorylase. Now glycogen is broken down to produce glucose. Glucose want to come out of the liver to maintain blood glucose. But suppose you did not inhibit this, what will happen? This glycogen synthase, suppose not inhibited, what it will do? When glycogen phosphorylase will produce glucose, glycogen synthase will be very happy, would say, oh, so much of glucose, let's do glycogen synthesis. It will break, it will join. It will break, it will join. And the blood would get Babaji ka thullu. That's why, very good, Devansh. That's why two opposite pathways are regulated in such a way, when one is activated, another should be kept in inhibited state. So we found that this way, glucagon epinephrine, yes, activate glycogen phosphorylase. we found that in muscle is little bit different. Muscle says myself. Muscle is very selfish. Muscle don't contribute blood glucose. Question is asked. Muscle don't contribute blood glucose. Nature said that muscle don't contribute blood glucose. Why? Because if I locked you in a room for 16 to 18 hours, somebody opened the door. Now you want to run. Muscle would have, yes, sufficient glycogen to run. Nature is very wise. Nature decided that it's an adverse situation. Liver will maintain blood glucose and muscle will store its glycogen as such whenever we will get time, and immediately we will run and we will come out of danger. So we'll require energy. That's why muscle glycogen can't contribute blood glucose. This is conceptual mnemonic. Now, nature said one more thing, that when you will start running, at that time muscle contraction would be there, calcium would be released. This calcium will bind with calmodulin, and this will activate calcium calmodulin dependent protein kinase. Calcium calmodulin dependent protein kinase. So this protein kinase will, yes, definitely, muscle fight and flight reaction is that. Also epinephrine is released. Epinephrine will maintain by this. Epinephrine will do by this. But calcium will do by this. And ultimately activate glycogen phosphorylase. Got the point? Clear? Now, activator of glycogen phosphorylase. This is a little bit sometimes controversial. At few places it is written. I am giving you the reference of Harper, standard textbook, Leninger, Lippincott, whatever standard textbook you follow, they will give the same thing, that activator of glycogen phosphorylase in liver are glucagon and epinephrine, but not in muscle. Glucagon is not activated in muscle. Epinephrine, yes. And I just told you, nature gave muscle one extra activator, that is calcium. That is calcium calmodulin technique. It means pathway, not technique as such, but yes, you can say it's a technique of nature. Yes, inhibitor of glycogen phosphorylase. Glucose is inhibitor of liver, but not muscle. Okay, these are same. Now I go to question. Glycogen phosphorylase can be regulated by all of the following except cyclic AMP. Yes, cyclic AMP, increase cyclic AMP, activate glycogen phosphorylase. Calcium calmodulin, protein kinase A. Answer is yes, you can give easily. Glycogenin is not regulating glycogen phosphorylase, is a primer for glycogen synthesis. This question has been asked. Primer for glycogen synthesis. Yes. Now, next question we are doing. You can easily tell me now. Yes. Yes. A professional cyclist has been preparing for long race competition to guarantee that muscle glycogen is stored after workout. His coach strongly advised he consume carbs. Yes, I told you extra carbohydrate will be converted to glycogen stored in liver and muscle. Which of the following most likely cause an increase in the activity of rate limiting enzyme for muscle glycogenesis, glycogen synthesis, rate limiting enzyme, glycogen synthase, and this glycogen synthase is active in, yes, I just told you, glycogen synthase. Yes, all enzymes activated by insulin. These, and yes, glycogen synthase is active in dephosphorylated state. Phosphokinase is active in dephosphorylated state. Pyruvate dehydrogen is active in dephosphorylated state. All these three questions has been asked previously. Okay. Now we move to next question. Insulin promotes lipogenesis by all except, you can find the answer without second thought. Insulin activate pyruvate dehydrogenase. This statement is wrong. It is not inhibiting, it activate pyruvate dehydrogenase. I told you most of the conceptual question, why I have changed the sequence of these questions. Yes, because you must know that many questions in biochemistry are solved by basic concept. If you remember, no need to mug up different pathways and different enzymes regulations. Just remember the basic concept and you will find the correct answer. In this, you can easily find that insulin, I told you, insulin activate pyruvate dehydrogenase. When insulin activate pyruvate dehydrogenase, more and more acetyl coenzyme produced. This acetyl coenzyme may take part in fatty acid synthesis. So yes. So answer is in this answer. So this is the reason I took a little bit. Yes. So increase acetyl coenzyme, I just told you. Decrease cyclic AMP, insulin do incision. Decrease cyclic AMP, insulin increase glucose uptake. Yes, this is also true statement. Let me tell you. Glucose transporter 4, how you will remember, heart is having 4 chambers, and this is Popeye the sailor, skeletal muscle man. After looking at this his muscle, her heart was beating, dhak dhak, glucose transporter, make any mnemonic just to correlate. Yes, heart, glucose transporter 4 is present in skeletal muscle, heart. And now after marriage, so good food, now he is having adipose tissue, accumulation of triglyceride, adipose tissue. So insulin increase concentration of glucose transporter 4 at muscle may be skeletal, cardiac, and adipose tissue. So overnight fasting, insulin decrease. So glucose transporter 4 concentration decrease at, yes, skeletal muscle, cardiac muscle, adipose tissues. Same questions are asked. Clear? So you can easily find true statement, only one false statement, and they have asked except. This is the answer. Now we come to next. Type 1 diabetes present with complaint of polyuria. We will know which of the following will normally occur in his body. We found that beta oxidation of fatty acid, I write here, beta oxidation of fatty acid occur in starvation and diabetes. Gluconeogenesis occur in starvation and diabetes. Ketoacidosis. So if you want to write, I can write here like this. It will give you better idea, or in exam, it will help you. Gluconeogenesis occur in starvation and diabetes. Ketoacidosis occur in starvation and diabetes. And I told you that beta oxidation of fatty acid is conversion of fatty acid to acetyl coenzyme. I have discussed here. Yes, beta oxidation of fatty acid, beta oxidation of fatty acid, beta oxidation of fatty acid. This fatty acid is converted to acetyl coenzyme A, and beta oxidation increase in starvation and diabetes. So in diabetes, beta oxidation increases. Okay. So in this question, they have asked, yes, in diabetes, glycogen synthesis in muscle will decrease. Glycogen synthesis is activated by insulin. Diabetes, insulin is not there or not working. So in diabetes, yes, glycogen synthesis will not occur. Decreased protein synthesis would occur. Okay. Increased cholesterol is increase in diabetes. Okay. So this is about this question. You all know that in the metabolic pathway, compounds destined to undergo certain biochemical reaction need to be activated by addition of high energy group. You all know high energy group is dominated by ATP, and you know just like hexokinase convert ATP to ADP. So all of the following can act as donor of such group except ADP is not a donor. Okay, ADP is not a donor. Creatine phosphate, it is a donor. Yes. Last question. In medicine OPD, 3 patients are being evaluated for diabetes. These have been given a load of glucose to do oral glucose tolerance test. Oral glucose tolerance test. Yes. Based on the below graph, which patient in this pre-diabetic patient is in the pre-diabetic state? Okay. Yes. Let me take in oral glucose tolerance test. Yes. You will find fasting state, normal person, the blood glucose should be 70 to 110 milligram per deciliter. But according to American diabetic, no, some technical, yes, hang हो रहा है. Yes, according to American Diabetic Association, yes, upper limit revised, upper limit is 100 milligram per deciliter. Yes, so if more than 100, so periodically this should be done. Okay, blood sugar should be checked. So normally in fasting state, after 2 hours, of taking glucose, normal person blood glucose should be less than 140 milligram per deciliter. Or if you want to simplify, you can remember like this: normal, pre-diabetic, diabetic. Means 70 to 110, 110 to 126, more than 126 in fasting. After 2 hours, less than 140, 140 to 200 milligram per deciliter, then 200 milligram per deciliter diabetic. So if you remember these values, then you can solve very easily question. In this patient, first patient at 0 means fasting, at 0 fasting, that there is below 100, fasting less than 100 hai. Yes, you can see easily. And patient 1 fasting is less than 100. Yes, and this after at 2 hours it is less than, as 2 hour less than 140, less than 140. So this is normal. Patient is normal. Now patient 2, you can see that fasting is normal. Fasting less than 100, okay, or 110, whatever you can say is 110. But after 2 hours is more than 140. So this is pre-diabetic. So they have asked pre-diabetic. This is more than 140 after at 2 hours. Okay, better to say at 2 hours. Yes. Patient 3, yes, it is 150, more than 200 means diabetic. So they have asked about pre-diabetic and the answer is patient 2. So hope you have enjoyed the session. You can remain connected with me on Cerebellum platform. I am exclusively present at Cerebellum platform and I am definitely available for your all doubts. Thank you for patience listening.